Good morning and welcome to the Healthcare Affordability Board meeting this June 24th, 2026. We are glad to have you all in the room. We're going to go ahead and get started. I love the lively conversations. I will just again appreciate for everyone who is here with us and who have joined us in the room, as well as those on the phone and joining from the public. Can we please ask for the roll to be called?
Good morning, Dr. Sandra Hernandez.
Present.
Secretary Kim Johnson.
Present.
Richard Kroenig.
Present.
Ian Lewis.
Present.
Dr. Richard Pan. Don Molds. Board present, 2 absent.
Okay, and we'll establish a quorum. Director Landsberg, I'll turn it over to you.
Thank you very much, Madam Secretary, and we'll start with just going over the agenda. So we have a discussion and vote on advisory committee appointments with appreciation to our subcommittee who are sitting together, and we'll talk about that along with a staff presentation. And then we will have an overview of some data. We'll have an overview of 2023-2024 commercial and Medicare Advantage spending, followed by a look at utilization of California's commercial and Medicare Advantage markets for 22 to 24. So I just want to note we are still working on DHCS about some of the Medi-Cal data. But while we do that, we thought it was important to share what we have on the commercial and Medicare Advantage markets. We appreciate the plan's collaboration with us in that data submission and want to get that data out into the public. One of the really important tools that OCA has to improve affordability is transparency, understanding how and where spending is increasing so that we can address it as a state. So we take another important step toward that transparency work with today's meeting and the presentation of data. After the data presentations, we'll continue with spending target enforcement penalty discussion. And then our last item will be a review of comments on our cost and market impact review regulations implementing AB 1415. Moving on to my executive updates, I wanted to start with some updates about our workforce development work at HCI, specifically around behavioral health. Workforce, we're pleased that our Behavioral Health Services Act WET plan, or Workforce Education and Training Plan, was approved last week. So we are required under the Behavioral Health Services Act, under the Act, 3% of funds come to HCI for workforce development work. We engage in an extensive community engagement process to hear from folks about how we can most meaningfully invest those funds. So we've been undertaking that process, continuing to iterate over the last year, and then had that plan approved last week. I think what really stood out was a need to focus specifically on the complex needs of folks who are being served by our public behavioral health system. So we have social workers and psychiatrists who are coming out of training, but not really having the specific skill set to work with folks who are experiencing homelessness, who are recently incarcerated, who have multiple mental health and substance use disorder conditions. So we're looking, so we have a variety of initiatives focused both on training existing workforce to have that very specific skill set, as well as working with our education partners to try to transform their programs to more effectively meet the needs of our folks with complex conditions who are receiving services through the county behavioral health system. Also related to workforce, the research firm Mathematica recently published a report on California's youth mental health initiative. So a number of years ago, the governor invested $4.7 billion in the Children and Youth Behavioral Health Initiative, and Mathematica undertook an evaluation of that initiative and the state's approach to behavioral health and well-being of children, youth, and families. HCI had a series of workforce investments that we administered, and one of the key pieces was to develop the certified wellness coach profession. And Mathematica's key findings show that the certified wellness coaches are already improving student well-being, strengthening school capacity, and helping build a more representative behavioral health workforce in California. Certainly, there continue to be opportunities to remain. There are still opportunities to improve the representativeness of this profession and make sure we're reaching all parts of California, including rural areas. And this report is available on the Cal HHS website. A couple of updates about HPD, the Healthcare Payments Data Program, or California's All-Payer Claims Database. The HPD program released 2 data briefs in collaboration with OCA. The first brief, GLP-1 prescriptions for weight loss over time from 2018 to 2023, presents prescription and cost for GLP-1 use for weight loss drugs by drug product in the commercial and Medi-Cal markets, and Vishal will speak more about this brief. The second brief, insulin and metformin geographic access and mail order use, presents miles traveled to pharmacies and mail order use by county. And then I'm trying to get the word out about California's Rural Health Transformation Program, and very pleased to announce that we will start issuing our first RFAs, request for application, next week for the California Rural Health Transformation Program. So with each RFA that we release, we'll release the application itself, a grant guide, FAQs, and we'll do a webinar as we continue to partner with folks. So if you're interested, we do have specific announcements that we're making about the California Rural Health Transformation. And then if, like me, you have MyShake on your phone, you know that in the world of Oshpod HCI, we're tracking the earthquake close to Willits this morning, which was magnitude 5.6. Early reports from facilities at Adventist Health at Ukiah and Adventist Health Howard Memorial indicate there is no physical damage. Normal power and natural gas are out, so the facilities are running on generators. And HCI's facilities team is reaching out to contact all facilities in the area. So that gives you just a sense of the breadth of our work, engaging with hospitals and health entities in California. And those are my executive updates. And with that, I'll turn it over to Vishal Pagani.
Thank you, Director Landsberg. We have a few articles to share with the board today. The first is an article published in Health Affairs this month that assessed the effects of private equity acquisitions of primary care practices on primary care physician practice patterns and patient care in the traditional Medicare market. This study identified 225 private equity acquisitions during the period 2016 to 2022, and compared these practices with 1,125 matched controls across the 5 quarters before and the 5 quarters after the acquisition. The study used a difference in differences designed to examine differential changes in outcomes of interest between the private equity acquired practices and controls. They found that in private equity acquired practices compared to matched controls, at the physician level, the number of claims billed increased by 50.6 per physician, or 30.5, or a little above 30%, as shown on the figure. Specifically, Medicare initial annual wellness visits increased by 21%. The number of patients seen per physician increased by 8 patients, or a little over 11%. Medicare spending per physician for services billed by the PCP increased by about 14.9%. At the patient level, patients received 11% more lab tests and a little over 11% more preventative and screening services. In contrast, visits per patient decreased by 1.3%, and there were no significant changes to Medicare spending per patient per physician on services billed by PCPs. I'd also like to note that these findings were statistically significant. Some of the confidence intervals for the point estimates are quite wide, making the true effects of PE acquisition on these outcomes uncertain. There were no significant differences in patient complexity as measured by the hierarchical condition categories codes after acquisition, making increased patient complexity an unlikely driver of the differences observed. Next slide. So the study also did some analysis on workforce after private equity acquisition. Practices increased the total number of PCPs by 16.9%, and advanced practice providers, so those are physician assistants and nurse practitioners, by 40.1% compared to the control group. However, because many advanced practice providers bill under the physician's NPI, the study could not determine the extent to which observed increases in services in private equity acquired practices may have been driven by greater reliance on advanced practice providers. So the slide also goes on to list some of the limitations of the study, and the authors conclude that private equity investments can increase the use of primary care services, including preventive services and lab tests, and the number of patients seen by primary care providers within the traditional Medicare program, potentially expanding access to primary care. However, the authors note that while the observed increases in service intensity in the PE acquired practices may in part be due to greater reliance on advanced practice providers. Another explanation could be introduction of productivity targets for providers, such as seeing more patients or providing additional services. Such productivity pressures could contribute to provider burnout. The authors also suggested that PE-backed practices may be positioning themselves to capitalize on fee-for-service payments, such as the Medicare annual wellness visit, which are reimbursed at higher rates than routine office visits. Evidence suggests that in Medicare Advantage-oriented primary care, PE firms enter joint ventures with insurers, which is associated with increased risk coding rather than utilization growth. And then lastly, the authors call for greater ownership transparency to accurately evaluate the scale of PE consolidation and its effects on care delivery and equitable access. Next slide. So I'll move on to a different article. So this one was published in JAMA in May. The authors proposed a state-administered primary care common fund as a way to address fragmentation and underinvestment in primary care in the U.S. The proposed fund would consolidate existing primary care spending from both public and private sources and pay primary care practices directly outside of insurance, similar to the way public utilities finance universal public goods such as electricity and water services. The common fund would function as a multi-payer finance state-run resource pool supported by contributions from commercial and self-funded plans, as well as transfers from Medicaid. Initial contributions into the fund would be set to match current primary care spending across states, with the intention of increasing those investments over time to align with state primary care investment goals and benchmarks. These increased funds would in part be used to ensure access to primary care for individuals without insurance. The authors also propose that each state have the authority to determine how practices are paid, whether it's fee-for-service, prospective per member per month payments, or some combination, and to establish cost-sharing limits for patients. Traditional insurance coverage could remain unchanged for all non-primary care services. The authors go on to highlight some limitations. As with any public program, the common fund could be vulnerable to state budget pressures. Because the common fund would be limited to primary care, it would not address challenges in other sectors. And although it would bolster primary care funding, the common fund would not automatically address all primary care workforce shortages. These areas would need to be addressed through additional policy support. And then going on to some other considerations that the authors noted for implementation. They note that the primary care fund is compatible with existing payment structures, since it could operate alongside traditional insurance ACOs and other value-based models. They highlight transparency and accountability as benefits of the common fund, with designated primary care dollars going directly to practices, and states having the authority to mandate reporting on processes and outcomes. They pointed to precedent for similar funding, such as state and federal health plan taxes that fund Medicaid programs and the Patient-Centered Outcomes Research Trust Fund. And then they go on to note that the common fund would align with current trends in primary care delivery such as the growth of direct primary care, where consumers or employers pay for primary care services outside of insurance. So this concept essentially would universalize that idea. And then lastly, the authors emphasize that states could leverage existing initiatives, such as primary care investment benchmarks and stakeholder coalitions seeking improvements in the primary care sector to build the support necessary to successfully implement a common fund. They point to the California Academy of Family Physicians' recently adopted policy to establish a primary care for all program based on a common fund model as an example of momentum towards such an approach. Next slide. So this article that I'm covering now is titled "States Are Exceeding their Cost Targets. What does it mean?" The article emphasizes that while cost growth targets and transparency can reveal the sources of spending growth for the 8 states with targets, complementary policies are necessary to meaningfully bend the cost curve. The authors contend that the main drivers of high commercial market trend include commercial claims and hospital services and retail prescription drugs. Together, these areas account for the majority of per person commercial spending and have seen the greatest increases in growth, making them the logical point for cost containment policy. The authors note that spending trends in these areas reflect the significant pricing power and limited regulatory constraints that hospitals and pharmaceutical manufacturers have, which transparency can elucidate but alone cannot address. For hospitals, the studies point to provider market consolidation and resulting weak insurer bargaining leverage as a primary contributor to price growth, along with strategic use of claim coding to maximize provider revenue. For pharmaceutical manufacturers, pricing power is reinforced by structural factors, including government granted patent exclusivity, which creates time-limited monopolies, and by the relative absence of any regulatory ceiling on launch prices. Next slide. To constrain spending growth, a number of states, both with and without targets, are using their data to move toward hospital and pharmacy-focused approaches, especially in the commercial market. I won't go through each state, but a summary of approaches to constrain hospital spending growth include implementing price caps, price growth caps, reimbursement ceilings, lowering the target for high-cost hospitals, such as in California, and facility fee bans. Next slide. And then the authors also focus on state-based pharmaceutical approaches to constrain spending growth. Colorado can apply upper payment limits if a review board determines drugs are unaffordable, while Maryland is authorized to set upper payment limits for all purchaser and payer reimbursements of prescription drugs, except where preempted by federal law. Minnesota, Oregon, and Washington have similar authority. In Connecticut, price increases for off-patent and generic or biosimilar drugs are capped at the rate of inflation. The authors note that cost growth targets make healthcare costs visible, identify who is accountable, and build the case for more direct interventions. Among the authors' conclusions are that the above state initiatives represent a fundamental shift in how states exercise authority over markets, and that states with targets may need complementary strategies to rein in excess healthcare spending. So I'll move on to 2 more updates. This was the HCI data brief that the director referred to. So using HPD data from 2018 to 2023 for Medi-Cal and commercial payers, this brief examines GLP-1 scripts for weight loss over time and the total cost of these scripts by plan type per member. Key findings include GLP-1 utilization from 2018 to 2023 has increased exponentially for weight loss utilization from 20,000 prescriptions to over 700,000 prescriptions. In the most recent year of available data, the total overall cost for GLP-1s for Medi-Cal and commercial plans was approximately $822 million. The statewide average yearly cost per member for receiving a GLP-1 prescription for weight loss was $5,329 in 2023. And then these costs varied by county, ranging from $3,051 in Lassen to $5,096 in Mendocino. With recent changes to coverage for weight loss utilization, prescription volume and costs trends are expected to change between Medi-Cal and commercial plans. Future analyses in this space will examine these changes and compare more years of data as they become available in the HPD. We've also been monitoring some of the direct-to-consumer prices for these GLP-1 drugs, and these future analyses will also consider those trends as well. And then next, I'd like to inform the board and the public that yesterday afternoon, OCA released a draft for public comment of proposed regulations governing requests for spending target adjustments based on non-supervisory organized labor costs. We plan to submit the regulations for approval later in 2026. If approved, OCA will begin accepting requests for adjustment to the 2028 spending target from regulated entities this October. And then going on to the next slide. So as we do at every meeting, I'd like to remind the board and the public about our slide formatting key. So the green arrows indicate areas where the board has ultimate decision-making authority, and the yellow areas in the presentation are areas for which OCA or the office has decision-making authority. So we use these meetings as a forum to get stakeholder input on these areas. And I'll now turn it back over to the chair.
Thank you very much, Deputy Director. That was a combination and variety of a few updates and Director there. So really appreciate both keeping us up to date on some of the latest studies and things that are coming out, but also on some of the work that HCA is doing on some of those fronts too. So appreciate all of that information. Board members, questions or comments?
Thank you, Michelle. I'm curious. I didn't read the JAMA article, although the journal is sitting bedside in full. This idea of a public utility for primary care, does the article go into what the regulatory requirements or waivers would be needed in order to implement such a fund?
No, they don't.
It's pretty high level, and folks may know Kevin Grumbach was one of the authors.
Know him well.
On that, I just wanted to appreciate you flagging that and the work of Dr. Grumbach and others. You know, it's a very tricky issue and some analogous in some ways to what other states like Pennsylvania have done, like carving out, say, rural hospitals for a different reimbursement system. And it's just a fascinating contribution to something the state is exploring under SB 770, which is to figure out how we work our way to what the governor has described as the North Star of unified financing. On the excess of cost targets, I just wanted to flag, looking at the Health Affairs article, I think the one state that came in substantially under the cost target was Rhode Island, which has taken a more aggressive approach to regulating prices in particular. I know what distinguishes California is that we have the authority on penalties and enforcement that other states don't. But it's interesting to me that Rhode Island has been successful where others have not been.
Not seeing any other questions or comments from the board, we will open up public comment for executive updates.
We will now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in the room may line up at the podium. Those attending virtually should click the raise hand button. Those dialing in can press the star 5 to raise your hand. During the public comment period, you will be unmuted when it is your turn. We also invite you to provide written public comment at the email address posted on today's agenda. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. Please note that while the board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on today's meeting agenda, except to place the matter on a future meeting agenda. I will start with the individual at the podium. Please go ahead.
Good morning, Joan Allen with SEIU UHW, commenting specifically on the draft regulations around the organized labor spending adjustment. Want to really thank staff for moving those draft regulations quickly with the hope of meeting the timeline of being able to start accepting submissions this year for the 2028 calendar year. Hope that in the future we can tighten that timeline up, as many collective bargaining agreements run 3 years. Needing to do that submission a year and 3 months ahead is an awfully long lead time and will lead to substantially more retroactive or the need for mid-year adjustments than if we can tighten that timeline up so that more contracts are actually within their agreement framework rather than that 15-month window. Also appreciate the recognition that we will need ongoing monitoring of these adjustments to make sure that entities who receive an adjustment are using those dollars appropriately and using that extra spending growth cap appropriately. And appreciate the starting assumption that collective bargaining agreements are held confidential unless they've otherwise been made public. Do appreciate that. Little bit concerned about the lack of notification of the second party. Any collective bargaining agreement is a party between both an entity and a labor union. Either of those entities, either the regulated entity or the labor union, can submit for the adjustment. And currently the draft regs, I don't see on a first read any notification of the counterparty. And would appreciate that before months later when there is the board discussion. Otherwise, looking forward to really digging in and reviewing, and expect to appreciate that we will have the comment period and that there will be more opportunities to comment. Thank you.
Thank you. Looking virtually, seeing one hand raised, noting for the record, we have about 100 virtual attendees. Ruslyn, you should be unmuted on our end. Please go ahead. You might need to unmute on yours. Oh, give us just a moment. We're still unmuting on our end. Okay, you should be unmuted on our end. You can unmute on yours and go ahead. Listen, we can't hear you yet. You might need to unmute. The button is at the top right-hand corner of the screen. All right, we will work on that. And I'll look back to the podium. We'll go ahead and go to the individual at the podium, and we'll come back around to the virtual attendee.
Good morning. I'm Victoria Valencia with the California Hospital Association. I want to share some thoughts on a couple articles today from the executive updates. First, the health affairs article on states exceeding cost growth targets points to the importance of setting realistic and attainable spending targets that reflect contemporary economic and public health trends. Every state with a cost growth target exceeded it in 2023, every single one. When performance against the benchmark is a universal failure, that should tell us something about the benchmark. The states studied have diverse approaches to cost containment and varying levels of enforcement authority, and yet they are failing to meet the benchmarks that do not reflect the actual economics of delivering care. This shows changes to the benchmarks that take into account on-the-ground conditions are needed. Additionally, Rhode Island was highlighted in particular as having more aggressive price enforcement. There was also another health affairs article published recently by Whaley et al. That focuses on the price cap standards and their effects in Rhode Island. One of the things they found there was that actual RN staffing decreased by 13.4%. So there are other effects here that happen when these prices are contained and revenues are removed from these systems. Hospitals need to be able to provide patients with the latest, most effective therapies. Potentially penalizing or disincentivizing hospitals from investing in these medications sets up a potentially dangerous precedent that may have unintended consequences. OCA's analysis of GLP-1 medications presented today brings up a critical point. Undoubtedly, the introduction of these drugs has increased near-run healthcare spending. These medications and other new treatments and new medical technologies carry significant upfront costs. They also carry well-documented downstream effects, including fewer adverse events, fewer hospitalizations, and better long-term health outcomes. Those returns are real, but they don't appear in the same reporting window, and they likely won't show up within a PIP timeline at all.
2 minutes.
OCA should ensure that the spending growth framework never penalizes hospitals for providing cutting-edge treatments and technologies for doing, in other words, exactly what good care requires. A dollar saved today should not come at the cost of sustained or worsening morbidity. People's health, lives are too important. Thank you.
Thank you. Looking back virtually, Rosalind, we'll come back to you. You should be unmuted on our end.
Okay, can you guys hear me now?
We can, thank you.
Awesome. For some reason, my camera is not working, but that's okay. Thanks so much. My name is Rosalind DeLeon Minch. I am with California Nurses Association. We appreciate the work the board is doing to confront the issue of healthcare costs, which are climbing with no end in sight. Californians continue to name healthcare costs as a major issue impacting their families. The reality is that the increasing complexity of our fragmented healthcare system is a primary driver of increasing costs, and creating a common fund that only covers primary care would not ultimately address these issues because it would leave private insurers intact. A common fund only for primary care would not address high and rising costs related to pharmaceuticals or hospitalizations, which represents a significant burden to patients and their families. CNA's research found that hospitals are charging patients an average of $417 for every $100 of their cost. A single-payer healthcare system like CalCare would effectively address these issues. Only a direct payments model of unified financing that covers all healthcare services, primary and preventative care, hospital and outpatient services, prescription drugs, dental, vision, long-term care, mental health care, and more, would fundamentally address the issues at hand. So I think now more than ever is the time for California to move towards a single payer system like CalCare. Thanks so much.
Thank you. Looking back to the room, seeing no one at the podium, I'll go back virtually. Jamie, I see your hand raised. Go ahead.
Hi, this is Jamie Godwin speaking on behalf of the California Association of Public Hospitals and Health Systems. CAPH appreciates OCA and the board's engagement on the organized labor cost adjustments and the opportunity to review and provide feedback on the recently released draft emergency regulations to implement these adjustments. We recognize the need to quickly develop and adopt these regulations. However, more time is needed to consider the proposed regulation and provide thoughtful and informed feedback to OCA and the board. We look forward to partnering on this important issue. Thanks.
Thank you. Looking back to the room, seeing no one at the podium and no other hands raised, this concludes public comment on this item.
Thank you very much. We are going to skip down to item 4. This is a vote to approve the advisory committee members, revisiting this from our previous meeting. So I'd like to welcome Megan Brubaker, Engagement Governance and Policy Group Manager, to share the presentation, and then we'll look for a vote.
Thank you. So if we go to the next slide. On this slide, we saw this last month as well. It shows the 16 advisory committee members whose terms end on June 30th of this year. And we have updated and quadruple checked this slide to make sure the math is mathing. So we did have 13 incumbents out of 16 who applied for reappointment. The three incumbents who did not reapply were Stacy Hurantes, Carmen Comsti, and Marielle Reataza. 7 applicants were carried forward from OCA's special payer recruitment. And OCA also received 30 new submissions of interest. Next slide. So after meeting with the subcommittee, the recommendation is to reappoint 10 of the 13 incumbents who reapplied for a 2-year term. So this includes appointing Katina Murray as a physician in place of the incumbent Adam Doherty, holding all purchaser slots temporarily open while the extended purchaser recruitment is underway, temporarily appointing Suzanne Usage and Ken Stewart to serve at the July advisory committee meeting, and then consider them for the 2-year reappointment at the August board meeting. And then appointing 5 new members. So this would add 1 net new position to incorporate a pharmaceutical perspective, increasing the size of the AC to 29. And then overall it would be 30 with the reclassification with Ifkhtar Hussein to the hospital category based on his change in representation in recent AC discussions. And next year the board can reduce the number of hospital representatives back to 3 if it so chooses. And if we go to the next slide, this is just what I talked over in visual format. So before moving to the demographic information of the proposed slate, I will turn to our subcommittee members, Ian Lewis and Sandra Hernandez, to add additional context to their recommendation.
Well, let me first thank the staff for going over the slate again and making sure we had everybody in the right categories. I think the recommendations are such that we, first of all, very much appreciate all the people who have served on the advisory committee and who've reapplied. And for the 2 that we are not recommending a reappointment, it has nothing to do with performance, but rather a desire to try to increase the number of people who can participate in the conversation. And so with that, we are going to hold open and hope we will get more recommendations on our purchasers. And I know there's a great deal of effort underway, and I'd call that as a call to action for everybody to try to tap that. I think that's a very important perspective to have on the advisory committee. And so whoever the subcommittee is going forward will determine who the purchasers might be. And just to note for the record how valuable overall the advisory committee is to deliberations of the board. Those are always very robust conversations. They represent a wide variety of points of view and really is, I think, integral to the deliberations of the board. So with that, Megan, thank you to you and your team. Ian, I don't know if you want to add anything.
I think the only things I'd add are from the feedback from the last meeting, we agreed reclassifying Mr. Hussein made sense. On the purchaser slots, there's the application period runs through the end of the month, I believe. And since both Ken Stewart and Suzanne Usage had put their names forward and applied, we thought it didn't make sense to knock them off and then potentially reappoint them 1 meeting later. So we're proposing to continue them forward, notwithstanding the last meeting. And I think, on further discussion, we both agreed that the physician slot, just given the number of really strong applications there, made sense to consider switching that up.
Sorry. On the purchaser, I just want to make sure I understand correctly. On the purchaser appointments, you're recommending keeping the people who I think we agreed were not in purchaser positions until we find an actual purchaser, at which point you would do the switcheroo, presumably.
That was our thinking.
Yeah. Okay. I just want to make sure I understood it. Yep.
And just to clarify, there is an advisory committee meeting on July 7th. So without doing so, there would be no purchaser representation at that meeting.
I thank both staff and the subcommittee for your work on this. This all makes sense to me. My only question is about on the physician side, there was some discussion at the last meeting about the desirability of having physicians who are practicing and as opposed to kind of administrative positions. I don't know what Dr. Murray, what her.
She does both, Richard.
She does both.
Is the answer.
Okay, we can go over the demographic slides and then we can also stop for more discussion at the motion. So these next couple slides shows the demographics of the recommended slate. We did choose to not include the purchaser appointees, the temporary appointees Ken and Suzanne, the temporary recommendation. As you can see here on the county demographics, at 15%, Sacramento County has the highest representation with 4 members. Orange County has 3 members, which equals 12%, and San Francisco, Marin, Los Angeles, and Contra Costa County each have 2 AC members, which equals around 8%. Next slide. So this is a high-level overview of the racial and ethnic diversity reflected in the recommended slate. To note, these demographics are self-reported on the submission form. And then we also have gender and LGBTQ demographics. Next steps, OCA will reach out to approved advisory committee members, if voted on today, and inform them of their appointment. The new members will attend their first advisory committee meeting on July 8th. OCA is currently holding a special recruitment period to fill the 3 vacant purchaser positions. The submission period will end on June 30th. The subcommittee will meet in July to evaluate any new submissions received and present a recommendation to the board in August to address the 3 purchaser vacancies. And the next slide is a draft motion for consideration. So as displayed on the slide, the motion is to reappoint the 10 incumbents to 2-year terms. And we have those listed here. Also 5 new members to 2-year terms. Reflect Iftikhar Hussain under the hospital category until his term ends in 2027. Hold purchaser slots open until the purchaser recruitment closes and the board can consider appointments at the August board meeting, and then appoint through August 2026 Suzanne and Ken as purchasers and consider for reappointment under the special purchaser recruitment.
Thank you very much for that presentation. Thank you again to the subcommittee for your work and for bringing back the additional clarity to the board. I am going to see if we might have a motion to approve the items and individuals as listed on slide 27.
So moved.
Is there a second?
Second.
We will take public comment.
We'll now accept public comment on this agenda item. Please limit comment on other items to those public comment periods. If you're in the room, please step to the podium. If you're attending virtually, please raise your hand and please limit your comments to 2 minutes. Looking to the podium, go ahead.
Janice Rocco with the California Medical Association. As it was raised at the last meeting and then at this meeting, I do think for the next time that we do this, given that there are 4 hospital slots and 3 physician slots, it might be helpful if we tried to focus on physicians who see patients on a daily basis for the ones that are the physician slots, and maybe folks who are playing administrative roles in hospitals wouldn't be 2 out of the 3 of the folks who are holding the physician slots. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Beth Capel with Health Access California. As we look forward to the purchaser slots and the appointments there, it's important that purchasers represent purchasers. Many business organizations include members of the healthcare industry, and in fact, their healthcare committees are often run by members of the healthcare industry. So as we look forward to a purchaser, and I know this makes the job harder, not easier, but it's important that that purchaser perspective be a purchaser perspective rather than a business organization that has on its board hospitals or physician organizations or insurers or drug manufacturers. And I would just note on the pharmacist slot, it's a pharmacist, not a pharmaceutical manufacturer, so slight difference, but one that for anyone who went through the PBM wars, as I'm sorry to say I did, is a pretty obvious one. Thank you.
Thank you. Looking virtually, seeing one hand raised. Caesar, go ahead.
Good morning, everybody. Cesar Lara with the California Labor Federation and a resident of Monterey County. I want to echo the thoughts of our colleagues, in particular around physicians. It'd be great to actually have physicians that we can convince to get off, the line as they're treating patients, but to share their voice and concerns on such an important committee. So working physicians would be very important. And also want to echo the thought about pharmaceuticals and pharmacy reps. Having somebody that understands what patients see every day when they do visit the pharmacies, I think would be important more than pharmaceutical companies. And so those are my two thoughts. Thank you very much.
Thank you. Looking back to the podium, seeing no one at the podium and no hands raised, that concludes public comment on this item.
Thank you. We can go ahead and take the vote, please.
Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Dr. Richard Pan. 4 in favor, 1 absent. Motion passes.
Thank you very much. We are going to move back to item 3, our consent items. Deputy Director.
We have the main meeting minutes. The minutes and written public comment received since our last meeting have been distributed.
Thank you. Is there a motion to approve action consent item 3 of our meeting minutes?
So moved.
There's a second.
Second.
Can we have public comment on this item?
If you'd like to make public comment on this item, please step to the podium. If you're attending virtually, please raise your hand. Seeing no one at the podium and no virtual hands raised, I'll give it just a moment. All right, that concludes public comment on this item.
Okay, and can we take a vote, please?
Dr. Sandra Hernandez.
Aye.
Secretary Kim Johnson.
Aye.
Richard Kroenig.
Aye.
Ian Lewis.
Aye.
Dr. Richard Pan. 4 in favor, 1 absent, and motion passes.
Thank you very much. We are now going to move to item 5. These are our informational items. The first item, item 5A, is the 2023-2024 Commercial and Medicare Advantage Spending Overview. I will welcome Andrew Fair, Research and Analysis Group Manager.
Great. Thank you very much. So today, excited to share an overview of that commercial and Medicare Advantage spending trend data from 2023 and 2024. Before I jump into the material, I do just want to take a moment to thank the commercial and MA plans for their continued engagement over this past year, both in wrangling their spending and enrollment data in a timely fashion, as well as in providing thoughtful feedback to OCA throughout the submission cycle. With that, we can move on to the next slide. So this is just a refresher for everybody, just outlining how it is OCA conceptualizes total healthcare expenditures, composed of total medical expense, or TME for short, which includes claims payments, non-claims payments, as well as member cost sharing. And then on the right side of that figure, you'll also see the total non-medical expense, which includes various categories of administrative expenses, as well as health plan profits. Next slide. Okay, so as Elizabeth noted at the outset, we're going to focus here on commercial and Medicare TME. And so here on the, just for awareness, on the Medicare purple bars, we're including both fee for service as well as the Medicare Advantage markets. So we'll have both the aggregate total medical expense on the left and then the per member per year values on the right. So I'll start with commercial here. So commercial TME in the aggregate was $114.2 billion in 2023, increasing to $122.4 billion in 2024. So an $8.1 billion increase, or 7.1% in relative terms. And then in terms of per member per year change, commercial spending went from just under $7,000 in 2023 to a little over $7,500 in 2024, representing a 7.8% increase. And then the Medicare TME in the aggregate went from $122.7 billion in 2023 to $134.2 billion in 2022, representing an $11.5 billion increase, or a 9.4% relative increase. And then the TME on the Medicare front went from a little over $18,500 in 2023 to a little over $19,800 in 2024, a 7% increase. Next slide. Okay, so here, based on feedback both from stakeholders as well as the board last year when we presented the baseline report, we did just want to spend a little bit more time digging into the non-medical expense data. So we're going to start at the highest levels here with aggregate commercial and MA non-medical expense data. And so this is going to be a combination of both the fully insured data that CSIO posts, as well as the self-insured data, which is incomplete, that is provided to OCA. So starting with the commercial total non-medical expense, it increased from $10.3 billion in 2023 to $11.5 billion in 2024. So $1.2 billion increase, or an 11.5% relative change. And then on the Medicare Advantage non-medical expense data side, we saw a decrease from $2.5 billion in 2023 to $1.8 billion in 2024. So in relative terms, that would mark a 30% decrease. Next slide. So we're going to continue to dig into the fully insured commercial market, starting with the distribution of premium revenue. So again, using that CSIO MLR filing data that CMS posts, we can see that the average premium revenue reached $7,300, just over $7,300 in per member per year amounts in 2024, up from $6,700 in 2023. So an increase of just under 10%, or $650. The share of premium revenue allocated to medical expense also declined a bit by about 0.4 percentage points, from 90.3% in 2023 to 89.9% in 2024. And then the portion of premium revenue used for non-medical expense, excluding profit, declined from 9.3% to 8.6%. So a relative reduction, or rather an absolute reduction of 0.6 percentage points. And then finally, profit as a share of premium revenue increased from 0.5% to 1.5% of premium, so a 1 percentage point increase. Next slide. So on this slide, we're going to further disaggregate that non-medical spending in the fully insured commercial market. So on a per member per year basis, we see that total non-medical expenses increased just under $100, or well, to be precise, $94 per member per year, representing a 14% increase. So you see going from about $653 in 2023 to $746 in 2024. General administrative costs remain the largest category across non-medical expense, and grew by $10 per member per year, or just under 3%. Broker commissions were the second largest category here, increasing by $7 per member per year, or 4.7% on a relative basis. Taxes and fees saw about a $1 per member per year decrease, or 1.2%. And then finally, profits represented the smallest share, but saw the largest relative change, increasing by $78 per member per year, or just under 252% on a relative basis. Next slide. I should note, if folks have questions, feel free to stop me if anything's unclear, or we can wait as I speed through these. So continuing to look at non-medical expense spending in the fully insured commercial market. So we're going to focus here on the aggregate dollars. So when translated in aggregate dollars across the fully insured commercial market, we can see that admin spending components grew by about 1.3%. So going from about $8.7 billion to about $8.85 billion, while profit grew, again, right around 250%, from about $440 million to about $1.52 billion. Again, this is just the fully insured commercial market. So you can think of this as effectively a floor in the event that we had both fully and self-insured profitability. We would expect those values to be a bit higher. Next slide. Okay, so again, based on, I think, really thoughtful feedback we heard from submitters, we report medical and non-medical expenses by line of business. And so, as folks know, those aggregate results reflect enrollment segments of varying sizes. And so the large group market is the largest share at 68% of the fully insured market, followed by the individual market at 16%, and then the small group market at 15%. When we look at the allocation of premium revenue across those segments, they do differ quite a bit. So medical expense shares range from about 87.9% to 91.4%. And then the non-medical shares range from about 7.2% in the large group market to 13.4% in the small group market. And then profits increased across all three lines of business, but only in the larger group market were profits reported as positive. So individual and small group losses shrunk from 23 to 24, but remained negative during that period. Next slide. Okay, so we're still going to continue the theme of commercial market stratifications, but moving now into a TME space by product type. So here we're going to show both HMO and PPO spending growth, both in absolute levels as well as the relative change per member per year. So looking at the HMO plans, we see that the TME per member per year was just a tad under $6,700 in 2023, increasing to a little over $7,200 in 2024. So a $552 increase or 8.3%. And then on the PPO products, we see that in 2023, those TME per member per year values were $6,700. 6772 rather, increasing to just a little over $8,200 in 2024. So a relative increase of 7.6%. So just to flag that this marks a bit of an inversion from the 2022-2023 data, where HMO products grew more modestly than PPO products. Next slide.
Andrew, can I ask on that slide, do you have estimates of actuarial value? You know both what the insurer paid, but also what the employee, the member's liability is?
We do, or the submitters do provide member responsibility, and so we would have that by product type.
Yeah, and so it seems like you could use that then to get AV estimates, and I think it would be useful to couple this kind of presentation with AV information.
Thanks for that suggestion.
Actuarial value, I'm sorry. I did say that, I think, originally, and then that was in parentheses, AV. Right.
Acronyms are flying fast and often today, but we'll continue moving right along to the next slide on payer level reporting. So this past cycle, we had 24 payers that submitted data to OCA, with 17 offering commercial products and 19 offering Medicare Advantage plans. Next slide. So this should be familiar to folks from last year. So we're going to show the market shares on the left, and then the TME per member per year growth by payer on the right. So in 2024, commercial enrollment reported to OCA was a little over 16 million lives. Kaiser held 43% of those members, followed by Anthem Blue Cross at 15% and Blue Shield at 11%. So those three plans represented about 70% of the enrollment. And then when we look at TME across the commercial market per member per year, it increased again by that 7.8% value. Across payers, we see TME growth ranging from just a little over 2% to 13.5%, with most in between that 5 to 10% growth range.
A question on this, given how prominent Kaiser is in the mix here. But as I understand, it's both an insurer and a hospital system, Kaiser Foundation Health Plan. Are we separating out those two pieces? Like what's getting reported here?
So here we're reporting them at, it's a great question. So the data can be stratified by their two physician organizations. So forgive me for being crude, but Kaiser North and Kaiser South, Permanente Medical Group, and the other is eluding me at the moment. But so that's the grain at which the attributed medical file comes in, and then we would roll it up or aggregate it to the Kaiser Health Plan level. So you'll see in a few slides that we decompose the physician organizations and represent their growth separately, but here it's the health plan itself. So, and hospital spending is a different can of worms, so to speak, that we don't yet have as part of our hospital reporting due to some regulatory exclusions for the data that's provided to HCI.
So I understand. So the Permanente are separate entities, but the Kaiser Foundation Health Plan that is reporting that this data is just the insurance functions of Kaiser as
It would be the spending that the fully insured delivery system of Kaiser reports to OCA in their commercial market, and then the next slide would be in their MA market.
But to be clear, to make sure I understand, it includes estimates, at least, of what Kaiser is spending at the hospitals.
Yeah.
Yes.
Yeah. So we would have service category. We don't report payer by service category breakouts, but to the extent a health plan pays via claims, one would be able to look at service category level changes at payer levels.
I think why this is important is because for other health plans, many more admin costs are coded as medical expense when they're passed down to hospitals, right? If I understand it right.
That seems plausible. Yeah. Yep. All right. I think we can move on to the next slide where we look at Medicare Advantage enrollment and spending growth. So in the MA space, there were 3.4 million, give or take, just right around 3.4 million lives reported to OCA. Kaiser here too accounted for a little over 40% of those members, followed by United at 16%, and then Anthem Blue Cross at just under 9%, and SCAN at 8%. So those four plans represented about 75% of the MA enrollment reported to OCA. And so here we see TME per member per year increased 6.6% across those plans, with growth rates ranging from 2.9% decreases to 19.5% increases. So a bit more variability in the MA market relative to the commercial market. Next slide. Okay, so this is going to be a new section in this year's eventual publication of a healthcare spending report with a section on physician organizations using payer-submitted attributed medical expense data. And so OCA provides, as part of its data submission guide, an attribution addendum that can be used to inform those attributed data. And so that addendum includes a little over 140 physician organizations. In the upcoming report later this year, we report on 27, and you'll see those 27 in forthcoming slides. So those physician organizations were selected based on the following. We did proactive outreach to confirm those tax identification numbers associated with those organizations. We also placed a priority on large organizations that had a million or more attributed member months across their commercial and Medicare Advantage markets. So that corresponds to about 83,000 lives. And then finally, those that are rather well defined based on the attributed data that's submitted to OCA. And wherever possible, we really just appreciate our DMHC partners in providing contact information for a number of these organizations. So we were able to share physician organization previews similar to what OCA shares with payers, and also met with a number of organizations throughout January, from January to March earlier this year. Next slide. So before I get into the physician organization level results, I do just want to briefly provide some background on OCA's data collection. So the data submission guide instructs payers to attribute members to physician organizations according to an attribution methodology in the data submission guide. That starts with placing a primacy over capitated delegated arrangements. So that would be the largest tranche of attributed members in the OCA data. And then any remaining members that could be attributed would be assigned to accountable care organizations. And then third, there's an opportunity for payers to use their internal payer-developed approach, which we've often heard in conversation can either be primary care-based assignment or retrospective claims-based assignment. And then finally, for all remaining members who can't be attributed, they would be assigned to a non-attributed category. So across the two markets, the commercial and MA market, it's about 25% of members that can't be attributed. Important here in this penultimate bullet here is that attributed medical expense includes all spending for a member regardless of their rendering provider. And then finally, OCA aggregates attributed medical expense across payers to report on a physician organization's performance. So I'm going to provide a little bit more detail on those two latter bullet points in subsequent slides. So we can move on to the next slide. Okay, so here's a hypothetical example illustrating how that attributed medical expense can differ from total medical expense. So in this example, we have a plan that paid for separate organizations on behalf of that member's care. So the member used, had a primary care capitation with a fictional group. They also sought out behavioral health services, had pharmacy claims, and then had an ER visit. So whereas the TME, so to speak, would be that 1,200, the full scope of that member's care during the course of the year was 2,350, and so that would be the attributed medical expense to this physician organization in this example. And then we also get the corresponding member months to back into a PMPY. We can move on to the next slide. So in this slide, just want to illustrate that in most instances, physician organizations' attributed medical expense growth will be based on data pooled from several health plans. And so for the purposes of the physician organization reporting, we pool all of those attributed medical expenses as well as the corresponding member months across payers to arrive at a market category growth rate for a given physician organization. So in this hypothetical example, there are three, not uncommon for there to be anywhere from 3 to 6 plans that are attributing spending to a given physician organization that we're reporting on. And then for the purposes of reporting, you'll just see that TME growth rate or attributed medical expense growth rate in forthcoming slides. Next slide. And as promised here, so similar to the payer level exhibits we have, we're going to show the market shares across those physician organizations that we're reporting on in the commercial market, as well as the attributed medical expense PMPY growth across those organizations. So on the left, you can see that the two Permanente medical groups accounted for just over 40% of attributed members. And there are a couple of other large physician organizations, including Hill Physicians and Providence Medical, each with about 1% of that 16.2 million. In terms of that attributed medical expense growth, we see the two Permanente medical groups with growth rates around 9%. And then more broadly, you can see that attributed medical expense growth range from about 1% decreases to about 14.4% increases. So again, quite a bit of variation, similar to what we saw on the payer side. Next slide. So shifting to the MA side of the physician organization reporting OCA's doing, here we again see that TME per member per year increase of 6.6% from 2023 to 2024 among those larger physician organizations. So for example, the Southern California Permanente Medical Group, there was a 12% increase in attributed medical expense, the Permanente Medical Group at 7.6%, and then pretty substantial variation across other organizations, ranging from 19% decreases to 47% increases. And again, some of these can be quite small organizations, and so not unexpected to see a bit more heterogeneity in those growth rates relative to the commercial market. Next slide. Okay, another familiar set of exhibits from last year's baseline report. So here we display commercial spending per member per year, as well as the annual growth rates across the 19 rating regions that data are submitted at. This is a bit of a change in the granularity. We moved away from the service planning areas in the baseline report to just focus on those 19 covered California rating regions. But similar to last year's 2022 and 2023 data, you can here see that the northern regions show higher absolute spending levels with those darker shades of green, and then lower TME spending levels in the southern part of the state. And then on the right, we report those growth rates. So across all 19 regions, there was increases in TME, or rather spending per member per year, ranging from 2.2% to 13%, with 4 regions having double-digit increases, including Alameda, Greater Sacramento, Central Valley, and the Central Coast. And just one note on the regional data. So it includes capitation and claim spending, but there is a small amount of non-claim spending in the form of performance payments, shared savings payments, and population health and infrastructure practice payments that aren't captured at the regional level. So those are omitted, but it's, again, a pretty small share of overall TME. Next slide. So here we're just going to report on the regional variation in commercial hospital spending. So OCA collects claims spending from payers, including both the inpatient and outpatient claim spending, which together accounted for about 41% of commercial TME. And as you can see on this slide, there's pretty substantial variation. So often we've heard that data point that about 40 cents of every dollar is spent on hospitals in the state. And so that is what we see at the statewide level, but you can see pretty substantial variation ranging from commercial TME as a share, or hospital spending as a share of commercial TME, ranging from a low of 35% to a high of 55% across regions. Those northern and central regions tend to have the highest shares, while regions in the south were below the statewide average. And we can move on to the next slide. Here, we're going to move on to Medicare Advantage spending by region, where we see that only one region, the Eastern Counties, saw a decline with a decrease of 0.6% from 23 to 24. And then a couple of regions exhibiting double-digit growth, including Inland Empire, Contra Costa, Santa Cruz, San Benito, Monterey, and then Alameda County again showing double-digit growth in the MA market as well. Next slide. Okay, another way in which we can disaggregate the TME per member per year using claims and non-claim spending. So the commercial claim spending per member per year in 2023 was about $5,100, increasing to about $5,600 in 2024. So about a 9.3% increase in relative terms, whereas non-claim spending grew more modestly at 3.7%, growing from $1,859 to $1,929 in 2024, so just $70. And then in the Medicare Advantage market, we see claim spending increasing from just under $9,000 PMPY in 2023 to just under $9,900 in 2024, so a 10.5% increase. Whereas non-claim spending in the Medicare Advantage market grew more modestly at 2.1%, increasing from about $7,700 to just under $7,900 in 2024. Next slide. And we'll close here on TME per member per year reported by both service category and payment arrangement. So we can see that hospital inpatient and outpatient services represented the largest shares of TME per member per year in 2024, with spending of about $1,500 and just under $1,600 respectively, each accounting for about 20% of total TME spending per member per year. Inpatient spending grew by about 5%, whereas outpatient spending grew a little over 12%. And then in the Medicare Advantage market, we see that pharmacy spending, gross of rebates, was the largest claims category in 2024 at just a little over $3,300 per member per year, representing 19% of total spending and growing just under 6%, followed by hospital inpatient spending at about $2,700 or 15% of total spending, and then hospital outpatient spending at, again, about $1,500 or 9% of total spending and growing just under 17%. And with that, happy to answer any additional questions folks may have.
That was a lot of information. Very helpful. Thank you. We're digesting.
Really?
Board members.
I guess I would just say thank you for, again, I feel like we have a $500 billion a year budget on healthcare in this state, and we're just peeling back the layers of the onion here. It's really remarkable work. The thing that really stands out to me, I've always felt this on an experiential level, but this data is validating that the fallacy that large groups have bargaining power against health plans. If you look at the trends and certainly the profitability, I know profit varies year to year, but you'd think large groups are more predictable than smaller groups. It really belies that notion that large groups have real meaningful bargaining power to lower costs. Thank you.
I add my thanks. It's wonderful to see these results, especially good to see the results by medical group, which I know we've been looking forward to, and quite reassuring to me, at least, on the quality of the data that's been collected. You know, a few months ago when you presented some analysis of rates of increase in revenue per inpatient adjusted, per case adjusted admission and per adjusted outpatient visit on the hospital side, those data that have been provided by hospitals under, certification that they're exactly accurate and stuff, were worrisome on how much variability there was. The data that you're presenting here, it seems like, the information being provided by the insurers seems to be pretty high fidelity, and that's quite reassuring. A couple of small suggestions. One I made on adding actuarial value, so-called AV, to the HMO PPO slide. Providing some external benchmarks on how complete the data are. So, you noted that you've got reports on 16.4 million lives. How does that compare to other estimates of how many insured people there are? Similarly, much easier on the Medicare Advantage side, easy to find benchmarks there. this is a little sort of parochial on my side because I do a lot of work on Medicare Advantage. You do have a pretty unique data set on Medicare Advantage that, payments by Medicare Advantage plans CMS doesn't have those data. And it would be useful, I think, to use that to compare to, what does payment in MA look like compared to payment in traditional Medicare? And then lastly, kind of minor, on slide 33, go back to, I think it was 33. Yeah, 33. You show the non-medical expense by market, and maybe some comment as you write this up about on the Medicare Advantage side, where those data come from. They seem, and I think I commented on this a year ago, suspiciously low. I mean, 1.8 billion, and on the previous slide, you show out of 134 billion in EME for Medicare. So, just over 1%. That doesn't seem right.
Yeah, no, a couple great comments. I think we're still navigating how best to back into Medicare Advantage non-medical expense. So right now it's a combination of the societal medical filings, which I think we feel pretty confident on the fully insured commercial side. There's some questionable aspects of the MA filings on that front that I think we're digging into. And then we stitch that together with Schedule L filings from DMHC. Maybe we, in lieu of having this kind of Frankenstein approach, we can just pivot entirely to the DMHC filings in a subsequent version, just to have more consistency across that reporting. So that could be one, I think, artifact of why things look a little wonky. But yeah, it's something that we flagged as well, just in light of a lot of the public discourse around MA profitability. So it's on our radars to seek a way to at least enhance or refine our confidence in MA reporting on the non-medical expense side. Happy to continue down the list, but also
I don't know what the public availability of data are like, but there are MLR filings that the plans do with CMS. That might be another source.
Those would be the societal filings that include both the fully insured as well as the MA filings. But then DMHC also collects Schedule L filings from MA plans that operate in the state. So I think we can do our homework there and just see how they tie out. The other point, just around the completeness. So we do include a footnote in a couple sections of the report noting that we are missing a non-trivial share of self-insured lives in the commercial market, which could account for some of the incompleteness that we see in the physician organizations. And I do just want to take a moment to thank a number of the physician organizations that really dug into the enrollment counts we provided and helped spotlight kind of blind spots in our data collection. So that is something that we note in the draft report about just kind of the incompleteness of the commercial data just due to some of those self-funded segments. I think I'll stop there. But yeah, and just appreciate your note about insurer provided data based on claims seeming to be a lot more stable than sort of the accounting based approach that we see on the hospital side.
Not seeing any other questions or comments from the board, we are going to open up this item, and thank you again for that presentation, to public comment.
We'll now take public comment on this agenda item. If you'd like to make a comment, please step to the podium. If you're attending virtually, please raise your hand or press *5. Please limit your comments to this agenda item and to 2 minutes if possible. I'll start virtually. William, I see your hand. Go ahead.
Do you hear me?
We can now. Thank you. Go ahead.
Okay, thank you. Hi, I'm Bill Tarrant. I am the president of the California Physicians Alliance. I'm sorry I missed most of the presentation because it happens to be our House of Delegates today in Disneyland. I'm a podiatrist, and I'd like to speak of the issue of the importance of OCA and the penalties that should be imposed on people who do not, the organizations and institutions that do not adhere to the cap limit of 3%. First of all, take a quick look at the problems of expensive healthcare. It comes down to private equity and increasing the cost of healthcare and decreasing the quality. Pharmacy benefit managers in regards to spread pricing and patient steering, and hopefully legislation it passed last year, we'll be able to enforce that, and that's a charge that OCA should take on. Facility fees extended to private offices when hospitals take over private practices. Um, uh, decreased primary care physicians in the area. We need to have more primary care physicians to decrease cost and affordability for patients. I'm sure that you went over that. But you're talking also about Medicare Advantage programs and the disadvantage of Medicare Advantage programs. It's basically the worst private insurance taking over the best system of healthcare in America has to offer. There are 12 million people who have Medicare Advantage, and a lot of them are excluded by the fact that only 70% of physicians in certain counties, including California, don't accept the Medicare Advantage program. And the out-of-pocket cost is often high, and often there are physicians that are not available to them, dentists often not available to them especially. So this has to do with affordability, and the prices are raised, and there are a couple ways this happens. One is by upcoding, which you probably discussed. Another is buying up physician practices. That's Medicare Advantage programs. Another is nursing visits to homes, where nurses go to homes and look for codes that are basically upcoding. I just had a call this week from a nurse who sounds like a salesperson wanting to come to my home, although I saw my primary care physician after
2
4 months
minutes.
after 4 months of waiting. So all those things could really decrease affordability, and the penalty should be enforced. Thank you very much. I appreciate your time.
Thank you. And as a reminder, everyone, please limit your comments to this agenda item. We will have a general public comment period at the end. Looking to the podium, go ahead.
Janice Rocco with the California Medical Association. We've been having the attribution discussion at OCA for a number of years now, and concerns have been expressed at different times about attributing costs to a capitated medical group that are beyond the control of the medical group. But today's presentation goes sort of even deeper into that idea, in that we're now talking about things that are even out of the line of sight of the medical group. As an example, if we look at the PBM pharmacy claims, which was the example given in one of the slides, it's a situation where the medical group does not have knowledge of what the PBM charges are, and certainly has no control over them. And when we get to the enforcement side of things, certainly that should be excluded from determining whether or not a particular medical group met the cost target or needs a performance improvement plan, and certainly in the fine situation. As one example, I know for myself, in 2025, the PBM that my health insurer chose for me was Optum Rx. And then for this year, they have chosen CVS Caremark. My primary care provider has no knowledge of this. So it's beyond their line of sight, and certainly should not be attributed up to the medical provider. So that's just one example. But I think it's good to continue having the attribution conversation. Like I said, particularly as we get into the enforcement side of things, because these medical groups are going to have charges attributed to them that they don't even know about. The health plan will be reporting it to OCA, and they won't even be aware of it. Thank you.
Thank you. Looking virtually, seeing no hands raised, noting we have about 90 virtual attendees. We'll go back to the podium.
Good morning. Bill Barcelona with America's Physician Groups. Wanted to thank the OCA staff for the pre-meetings that we had to go over the preliminary materials on this process. It was very informative. We did note during those pre-meetings that there were some discrepancies over missing contractual arrangements. We still have issues concerning the attribution model. We raised those in our recent meeting with staff on June 16th. We'll have more written comments to follow here shortly now that we can dig into some of these preliminary results. But we appreciate this process, and we're excited that you're using the HPD data now, and that we're seeing more transparent information in this area. So we look forward to working with you more in the future. Thank you.
Thank you. Looking virtually, seeing no hands raised, back to the podium.
Members of the board, staff, Steve McDougall with CFT, a union of educators and classified professionals. I received an email just late in the day yesterday from a teacher in Santa Cruz who's been teaching 21 years and is living paycheck to paycheck. Finding out, as I reported last month, yet another astronomical annual increase to their healthcare contributions as individuals. The annual report demonstrates why OCA does indeed need strong enforcement. And just because all other states that have gone down this path in this space, costs have blown by the targets, I'm of the belief that we're California and we have the intestinal fortitude to hold folks accountable. If hospitals and insurers aren't held accountable, they will, just like the other states, blow past the target. Consumers appreciate this level of transparency. You may not necessarily understand it. I had a hard time. No disrespect. I might need a little primer on understanding some of the things I just heard. But the cost of healthcare is exorbitant for too many consumers. Consumers are paying more every year in premiums, deductibles, and copays. And where's the delta where we're working for just healthcare benefits and nothing else? There's got to be a point where that's where it's going to happen if we don't rein it in. Please hold them accountable. Thank you very much for listening. Appreciate your work.
Thank you. Looking back virtually, seeing no hands, back to the podium.
Thank you, Beth Capel with Health Access California. On behalf of consumers, we are dismayed that this report finds that healthcare costs continue to grow at twice the rate of median income and twice the rate of the growth target. What is exorbitant is not the proposed penalties, but the cost of healthcare and the impact it has on California consumers. You've all heard this before, but I'm going to say it again. 60% of Californians this year reported they or a family member skipped or delayed care due to costs, and most got worse as a result. More Californians think healthcare is unaffordable than housing, and nobody says that housing is affordable in California. 3 out of 10 consumers report going without food to pay for healthcare. That's not healthy and that's not right. And of course, this is all worse for lower income families. We appreciate very much the reporting by market segment so that it's obvious that the commercial costs have grown more quickly than Medicare Advantage, and we will look forward to seeing how Medi-Cal has grown as well. Blending together the reporting on the costs by market segments disadvantages the half of Californians who depend on employer coverage and individual coverage by worsening our affordability. We are excited to see the first data on physician organizations, and we recognize that we have a long way to go on that. I would just note on prescription drug costs, while the individual physician may not know which PBM their patient has, they certainly know which prescriptions they write for them, or I should hope they do. And so I think the attribution is on, we may have a mislabeled slide rather than a mislabeled attribution. The attribution is based on the prescriptions that the consumer takes. Trying to get our arms around all these costs so that we can change course and actually slow the rate of healthcare costs is, as several of my colleagues have said, why we're here. Thank you.
Thank you. Looking virtually, seeing a hand raised, Suli, go ahead. Suli, you should be unmuted on our end. You might need to unmute on yours in the top right-hand corner. If for some reason that's grayed out, you might be able to log off and log back in, or also call in and press *5. All right. I see Sully's hand went down. We'll go to the podium and come back around.
Good morning, I think still. Victoria Valencia with the California Hospital Association. Thank you for the preview today of the 2023 to 2024 spending trends. We want to highlight a few concerns about how these data are being framed and ask the board to consider them carefully before drawing conclusions. First, non-medical expenses, specifically administrative costs and profit, have now grown by double digits for 2 consecutive years in the commercial market, 25.3% in 2022 to 2023, and now 22.6% in 2023 to 2024. Both in the commercial market. While OCA has targeted scrutiny on patient care, clinical staff, medical supplies and drugs, and the maintenance of facilities that run 24/7, it has not scrutinized the profits of health insurance companies that do not even support patient care. Second, 15 of 16 commercial payers and 14 of 19 Medicare Advantage payers exceeded the 3.5% growth target in 2023 to 2024. This again is a story about system-wide cost pressures across every component of the healthcare market that the current targets do not adequately account for. Third, today's 2023 to 2024 analysis is missing Medi-Cal and half of Medicare data, and we urge the board to consider the full picture of all payer spending once it becomes available before drawing conclusions about spending across California. Finally, you will see in the subsequent section coming up a report on utilization that shows a decrease in utilization from 2022 to 2024. However, even using an imperfect measure of utilization, there is an increase in utilization from 2023 to 2024, which is the period this TME report covers. When considering healthcare spending and TME, both price and utilization should be evaluated when interpreting year-over-year trends. Thank you.
Thank you. Looking back virtually, seeing no hands raised. And no one at the podium. That concludes public comment on this item.
Thank you very much. Appreciate those comments. We are going to move on to item 5B. This is the examination of utilization in California's commercial and Medicare Advantage markets from 2022 to 2024. And stay with Andrew.
Great. Thank you very much. So this will be another installment of OCA's issue brief series using the healthcare payments database to inform some of the aggregated total medical expense data that OCA collects each year. We can move on to the next slide. So as not to keep folks in suspense, I'll briefly summarize the analysis. So as folks have now heard, from 2022 to 2024, OCA's total medical expense data showed double-digit spending growth in both the commercial and Medicare Advantage market. So 15.8% in the commercial market and 13.3% in the Medicare Advantage market. So we use the HPD here to examine the extent to which enrollee demographics, as well as different flavors of utilization, may contribute to those trends in accelerated spending growth. What we found is that the average age of commercial and Medicare Advantage enrollees increased by 0.6 and 0.4% respectively. In the commercial market, the utilization rate decreased by 4.2% while remaining flat in the Medicare Advantage market. The number of encounters on average per member decreased by about 3% in the commercial market, while increasing by 3.5% in the Medicare Advantage market. The share of enrollees diagnosed with a chronic condition increased by 9.6% in the commercial market and 4.1% in the Medicare Advantage market. And then we also looked at the share of high-cost members as operationalized by those with $1 million or more in annual spending. So it's a very small share of the population, about 0.1% of the enrolled population. But on a relative basis, their proportion increased by a little over 25% in the commercial market and just under 16% in the Medicare Advantage market. Next slide. So just to walk folks through the measures we looked at here. So we continue to look at a member's age, which is reported on one of the eligibility tables in the HPD at a member month level. And so to the extent somebody ages throughout the year, we would just take the average of those two values. The utilization rate, similar to OCA's cost brief earlier this year, focused on the commercial market, looks at the proportion of members who have any service claims in a calendar year. And then we also, based on feedback back in January, look at the number of encounters on average per member per year using both medical and pharmacy claims. So if folks will remember, back in January, we had only dove into the medical claims tables, and we've since conquered the pharmacy claims data and been able to link those to DSG submitters. So that has been a nice refinement to earlier work. And then we look at, as noted, the share of high-cost members with $1 million or more of annual spending. In the appendix of the issue brief, we have an alternative operationalization that looks at $100,000 or more. And then finally, looking at both chronic condition prevalence and comorbidity prevalence, so the number of distinct chronic conditions that a member was diagnosed with in a given year. Next slide. So a couple limitations I want to flag before getting to those results. So we're describing here market level patterns across the commercial and Medicare Advantage markets, but not formally quantifying the contribution of each of those factors to the reported spending growth. And as noted by a few public commenters, we're only looking at the commercial and Medicare Advantage markets. We do hope to incorporate the managed care market segment in a future analysis. In addition, we did exclude a couple of health plans that submit data to OCA, either because they're new entrants to a market segment, so we wouldn't have the full 3 years, or due to data quality. Next, we measure chronic conditions based on claims, which can depend on observed diagnoses and coding practices. So just by sheer observance of an increase in prevalence of chronic conditions doesn't necessarily always tie to changes in underlying health status. And then we use encounter counts, as has just been noted, an imperfect measure of utilization frequency, but we're not actually capturing the underlying intensity. So a prescription fill is going to be treated the same way as an ER visit, for example. And then finally, we use that fixed $1 million threshold to define high-cost patients. And so while we can observe the share of high-cost patients changing over time, we can't necessarily explain why that increase is happening. Next slide. Okay, so here we have just that OCA data from 22 to 24, showing that 15.8% per member per year increase in the commercial market, from about $6,500 to about $7,500 from 22 to 24. And then in the Medicare Advantage market, going from $15,700 to about $17,800. So that 13.3% relative growth rate. Next slide. So here we're going to look at the average age of enrollees. And so in the commercial market, we see a slow increase from 37.5 years on average to about 35.9 years on average. So representing a 0.6% change over that 3-year period. And then a similar slow moving average increase in the Medicare Advantage market, going from about 73.3 years old to about 73.6 years old on average by 2024, representing a 0.4% increase. Next slide. Here, we're going to look at the utilization rates. So just did a member use care during or generate a claim during that year? And we see from 2022 to 2024, the relative decrease in the utilization rate was 4.2% in the commercial market, while remaining flat in the Medicare Advantage market. As expected, the Medicare Advantage market does have higher absolute levels of utilization given the beneficiaries served. Moving to the next slide. So here we're going to look at not just whether somebody used care, but on average, how many times did they access care throughout the year. And just to be clear, if, for example, somebody were to visit the doctor and then get a prescription fill after that visit, we would treat that as one encounter. However, if they were to get the prescription fill later in the month, that would be a distinct second encounter. So we're just tallying up the number of times folks access care throughout the year across these two markets. And what we can see is, on average, in 2022, commercial enrollees that submit data to OCA access care about 10 times a year, or had 10 encounters on average, and it decreased by 3% to 9.7 encounters on average by 2024. By contrast, in the Medicare Advantage market, you see higher absolute levels, where on average, Medicare Advantage enrollees that submit OCA access care to the tune of about 23 times on average a year, increasing to just under 24 times a year on average, representing a 3.5% increase over that 3-year period. Next slide. So here we're going to look at the proportion of high-cost members, as well as the actual counts, and then their contribution to total spending in the HBD. So you can see here, we had to add a couple of additional digits just to provide more granularity. But overall, the share of high-cost members that exceeded that $1 million threshold in a given year was 0.1%. But it did increase on a relative basis by just over 25% in the commercial market, which corresponds to about 360 additional high-cost claimants, and just under 16% in the Medicare Advantage market, which corresponds to about 100 additional high-cost claimants. Their share of spending increased from just under 3.8% of total spending in 2022 to 3.9% by 2024 in the commercial market. And then the Medicare Advantage market, slight decrease in the total share of spending represented by those $1 million plus claimants, going from 2.17% to 2.14% over that 3-year period. So a slight decrease of 1.4% in the Medicare Advantage market. Next slide. So here we're going to look at just that prevalence of was a member diagnosed with at least one chronic condition. And so you could see about a 3 percentage point increase in the commercial market from 30.1% to 33% in 2024, and then a similar roughly 3 percentage point increase in the proportion of Medicare Advantage enrollees with a chronic condition diagnosis, going from 70.4% to 73.3%. Next slide. And so now we're also going to look at the number of chronic conditions or comorbidities commercial and Medicare Advantage enrollees were diagnosed with during that 3-year period. So you can see while modest increases in absolute levels, going from 0.6 chronic conditions on average to 0.7, it would represent a 16.7% relative change over that 3-year period. And then in the Medicare Advantage market, on average, enrollees had 3.2 chronic conditions in 2022, increasing to 3.4 chronic conditions on average by 2024. So a 6.2% relative increase. Next slide. So given that we've just run through a number of different characteristics of both enrollees and their utilization, we just try to synthesize all of those corresponding growth rates paired with the TME growth. So it's a little bit of a busy figure trying to convey a lot of information, but you can see those vertical lines at 0, and then the purple Medicare Advantage line far to the right of 0, and the green line even farther to the right of 0, corresponding to those TME growth rates. And then those bubbles and X's corresponding to the growth rates of each of those measures we looked at. So in general, age pretty close to 0 in terms of its growth rate, whereas we see near double-digit increases in chronic condition prevalence in the commercial market. Obviously, those high-cost proportions increased in double-digit terms across both markets, but represented rather small relative absolute changes. And then finally, utilization either flat or decreasing in some instances. With that, you can look ahead to just the takeaways here on the next slide. So again, we're really excited to continue to be able to use the HPD to examine the extent to which enrollee demographics and utilization patterns changed over that 3-year period, and how and to what extent it could explain those accelerated trends in growth we're seeing across the commercial and MA markets. And we hope this can inform the board and policymakers and other stakeholders seeking to understand the role enrollee characteristics and utilization patterns play amid rising costs in California. With that, happy to answer any questions folks have.
Thank you very much. Just on the second bullet here on the takeaways, and recognizing the bullet speaks to, and you have, I think, on slide 62, the numbers, that there's a small number of people. What else do we know about why such a high increase in the higher cost members? Anything else you can say about that? Anything else that you can share there?
Yeah, in the interest of concision, we didn't include every nook and cranny in the issue brief, but the issue brief does include a section that reports high-cost members by chronic conditions. And so basically, there's a monotonic increase in the number of chronic conditions you have and the representation they have of those high-cost members. So it's very, very rare for somebody with no chronic conditions to generate $1 million in annual spending. But as you go from 1 to 2 to 3 or 4 or more chronic conditions, that number of high-cost claimants just continues to increase. So it is very much tied to that function of underlying chronic condition prevalence that an enrollee is diagnosed with. But unfortunately, that is not part of today's slide deck.
Okay, thank you. Rick and then Don.
Yeah, to Secretary Johnson's question, I wonder, I mean, there's a lot of talk about CAR-T, cell treatment. You know, can you say anything either in this report or a future one about what treatments these very high-cost people are receiving, at least, is it pharmaceutical or not? Kind of what's driving the spending, I think would be useful. This is, again, thank you for the work and the report. The sort of conclusion that I reach in looking at what you've presented is there's not much here that would explain why TME is going up so much. Utilization looks, flat-ish or small increases. The high-cost members, is maybe a small piece, but as you point out, it's only 2% of total spending for at least this group. But I think that conclusion, I would, would be quite tentative because the kind of understanding of utilization is still very rudimentary. And as you move forward, if not for this year, for future years, trying to drill down some on utilization, at least at the level of ED visits, number of hospitalizations, number of days in the hospital, maybe, counting some number of relatively high-cost imaging procedures, probably at greater level of difficulty, if you could count RVUs, relative value units, but to try to get a better understanding of, we know TME is going up a lot. How much of this is price? How much of this is utilization? And you're sort of, providing a useful beginning of that here, but getting further would be very valuable, I think, in moving forward.
So I'm not quite sure whether this is something that is appropriate for this group. And it's a little bit of a can of worms, so I apologize ahead of time. But when we think about Medicare and the Medicare benefit that our members receive, the thing that matters really more than anything else is how much money we are getting from the federal government. So we pay about a third of the cost of the entire benefit. So 2/3 of, and the remaining 2/3 come from the federal Medicare program. So when it comes to affordability for our members, what matters arguably the most is how well or poorly our plans are doing in drawing down federal dollars, right? And there are lots of incentives that are arguably within the control of plans that bear on affordability. I'll give you an example. The Inflation Reduction Act created stronger incentives on the pharmacy side for the use of generics and lower cost brand name drugs. So plans that are very effective managers of the pharmacy benefit are getting higher reimbursements, and we are able to put a product on the shelf for our members that is way cheaper. So we're seeing huge discrepancies in premium, a lot of which come down to these kinds of things. So I'm just, as I said, a little bit of a can of worms, so I'm not quite sure what to do about it. But as we're thinking about affordability, because that is our charge, that matters. And I'm not sure that anything that we're thinking about takes any of that into consideration other than just actual costs.
Don, were you saying that plans that are doing more generic and biosimilar substitution are more affordable, or?
No, I mean, yes, and they receive more federal dollars. So as the reimbursements come through, there are incentives that reward plans that are more effective in managing the benefits. So it's not just that generics are cheaper, it's also that the federal government rewards plans that are efficient managers of benefits. And it's just, it makes more of a difference. I mean, candidly, it makes more of a difference than that for us in most cases on the affordability.
Yeah, I'd like to pile on to Rick's comments, both about getting a finer read on utilization and in the previous section about actuarial value, if it is possible in future versions of this. To my mind, there are two different types of reduced utilization. There is the good kind, more effective care management, reduced duplication, keeping people healthier. And there's the bad kind, people not getting the care that they need. And teasing that out, the sensitivity, how that correlates to out-of-pocket costs seems very important to us, especially as we're evaluating entities that are meeting the target and what their performance improvement plans are and so forth.
Okay, not seeing any other questions or comments from the board, we will open this item up for public comment.
We'll now take public comment on this agenda item. Looking virtually, Daisy, I see your hand raised. Please go ahead.
Hi, good morning. Thank you. My name is Daisy Oram. I'm with the California Alliance for Retired Americans, also known as CARA. We are one of the state's foremost grassroots senior and disability advocacy organizations, representing over 1 million older and disabled Californians. The annual report demonstrates why OCA does need strong enforcement. And if hospitals and insurers aren't held accountable, they will blow past the spending target. Consumers appreciate this level of transparency. The cost of healthcare is exorbitant for too many consumers, and consumers are paying more every year in premiums, deductibles, and co-pays. We also support strong penalties based on California law, not wimpy penalties for big insurers and hospital chains. As a consumer, I know how much healthcare costs for me and my family. Premiums, deductibles, co-pays, it all adds up. We pay a penalty when we skip going to the doctor or getting a prescription. Needing healthcare should not be punished by out-of-control costs. Strong penalties are needed to slow down the healthcare costs. We support penalties above 100% to encourage big hospitals and insurers to slow spending growth and meet the targets. The office can't address affordability problems if entities aren't submitting complete and accurate information. Procedural penalties help ensure that the office gets the information it needs to enforce the targets. Thank you.
Thank you. Looking to the podium, go ahead.
Beth Kell with Health Access California. Like others, we appreciate seeing this data, and we appreciate having 3 years of data and look forward to having 5 to 10 years of data one of these days. We would note, we looked back at the earlier report done this year on drivers of healthcare spending in the commercial market. That had per plan transparency. We appreciated that, and we wish we had seen it here, even though it would have made for an even longer report, but we do appreciate seeing the per plan reporting. Like the board, we have questions about who the very high cost cases are, those $1 million cases. I would also note, and it struck me in looking at the slide presentation, that the reason the proportion in Medicare is smaller is because Medicare pays less for hospitals than commercial coverage does. If you're paying 300 or 400% of Medicare, a long hospital stay can add up pretty quickly in terms of $1 million cases. We very much appreciate seeing the report on aging. As long as we've done this work, as long as I've done this work, I've heard that aging is the excuse for higher healthcare costs. Well, going from Medicare Advantage being 73.4% years to 73.6 probably doesn't account for the entire cost increase in healthcare costs. So we appreciate having information to counter the rhetoric that blames healthcare costs on the consumer. Thank you.
Thank you. Looking virtually, Sean, I see your hand raised. Go ahead.
Yeah, thank you for recognizing me. I'm here today not as representing my organization where I work, the Sacramento County Office of Education, but representing CSEA Chapter 480, the classified union at SCOE. And the reason I'm here today is because I'm a member of the negotiating team and also the chief job steward. And we do surveys every year regarding the costs of healthcare and how it's impacting our members. And what we're seeing is that the costs going up is becoming really detrimental to folks who provide essential services to students with disabilities, incarcerated youth, and so many other people in our community. And every year at the table, we're forced with the rising costs. And if we don't rein in the cost side and insurance keeps going up, it increasingly becomes impossible for our members to even use the policies that are available at our employer. 15% of our members are opting out and taking $100 a month in lieu of using the insurance. That's a staggering number, and these folks are on the exchange, the ACA exchange, or even Medi-Cal. So, containment is incredibly important, keeping these costs down and making sure that our members don't see every negotiated raise go exclusively to their healthcare is incredibly important to us. And I appreciate what it is you're doing. And I'd like to see the fines be what they are, because something has to rein this in. Something has to make it stop.
Thank you. Looking virtually, seeing no hands raised, we'll go back to the podium.
Hello, Victoria Valencia with the California Hospital Association. OCA's mission is to honestly and fairly assess the drivers of healthcare spending and set goals that reflect what it learns. Unfortunately, OCA often dismisses information that points to underlying and difficult to control drivers of healthcare spending that are well established. We see this from OCA today in the interpretation of the findings in its brief on utilization trends. First, on measurement, as highlighted also by board members today, the definition of utilization used here, a unique date with any claim, does not reflect the intensity or the cost of services being delivered. A routine blood draw, counts the same as an ER visit for someone coming in with life-threatening conditions from a car accident. Put simply, intensity matters. And those trends point upward, which affects what hospitals and other providers spend to deliver care. OCA should incorporate intensity measures into future reporting. Second, on selective interpretation, this report flags the finding of increased chronic conditions, including a nearly 10% increase in the commercial market, but tells us to interpret it with caution, suggesting it may reflect coding changes. In denying the reality of increased chronic conditions, OCA should assess whether other data sources tell a consistent story. For example, from the California Health Interview Survey, those data show pre-diabetes prevalence in California rising from 13.4% to 21.4% between 2016 and 2022, and adults experiencing serious psychological distress increasing from 8% to 13.5% between 2016 and 2024. These are real conditions requiring real resources. Finally, on age, while an increase of 0.2 to 0.3 may seem small in absolute value, this is not a rounding error when you consider it is across 17 million Californians. For example, the 75 to 84 age bracket, if you look at the age by the age brackets, increased nearly 8% between 2022 and 2024.
2 minutes.
This is a group of individuals that use a lot of care and the most expensive care. Secondly, using age projections from the California Department of Finance and personal healthcare expenditure data from CMS National Healthcare Expenditures, aging alone is projected to increase per capita healthcare expenses by 0.7% annually over the next 5 years. We urge the board not to let this report close the door on population aging and acuity as meaningful measures of spending because the data does not support that conclusion. Thank you.
Thank you. Looking virtually, Suli, I see your hand raised. Go ahead.
Hi, good morning, and thank you as I figured out all my issues with the teams. Good morning, everybody. My name is Suli Kenyatta, and I am the Northern California Outreach Manager for Small Business Majority. Small Business Majority is a national small business organization that empowers America's diverse entrepreneurs to build a thriving and equitable economy. Really excited to be listening in and joining in on this talk today on behalf of the small business owners who are really feeling the strain of rising healthcare costs here in the state. California small businesses are the backbone of our economy. They make up nearly all of the businesses in the state and nearly employ half of the private workforce. Yet many small business owners, workers, and their families are finding it harder to keep up with premiums, deductibles, and co-pays as they continue to rise and rise rapidly. The annual report showed why OCA's work is so important in terms of detailing how costs rose at about twice the 3.5% target, while insurer plan profits rebounded. For small businesses, these aren't just numbers or statistics. They really translate into difficult decisions about whether to offer benefits, whether employees can afford to use the coverage they have, and how to manage one more rising cost while they try to keep a business stable in this economy. For many small business owners, healthcare costs affect day-to-day operations. Rising premiums and out-of-cost pockets can make it harder to hire, retain workers, and invest in growth. When workers put off care because of costs, they can also affect workforce stability and family well-being. Small businesses and consumers are already trying to absorb these pressures, which is why accountability really matters. This is why Small Business Majority supports meaningful enforcement and penalties, including penalties above 100% for repeat offenders or entities that intentionally obstruct the process. If large insurers and hospital systems continue to exceed the spending targets without any real consequences, it becomes harder for OCA to meet its affordability goals. We also support procedural penalties because the office can only do this work effectively if entities are provided complete and accurate information. Consumers and small business owners are already carrying the burden of rising healthcare costs. Strong and consistent enforcement can help ensure that the spending target is taken seriously and that affordability remains at the center of this work. Thank you, and really appreciate the time to provide public comment.
Thank you. Thank you. Looking virtually, Caesar, I see your hand raised. And just as a reminder to everyone, out of respect for the process and those here to make public comment today, please limit your public comments to the agenda item. We will provide a general public comment period at the end of today's meeting. Caesar, please go ahead.
Good afternoon again. Cesar Lara with the California Federation of Labor Unions. Just want to echo some of the thoughts that were convened earlier today around affordability and making sure that we keep at center how we could have healthcare accessible. Want to remind the committee the special investigative report that was done in Monterey County as a case study. We want to make sure that Monterey County is an example of how we could address some of the challenges. We don't want the rest of the state to be like Monterey County, where healthcare is out of reach and not affordable. Small businesses, labor unions that deal with employers so often see so much of kind of the pie around what is accessible to workers in regards to maybe retirement benefits, take-home pay, and healthcare being eaten up by healthcare costs. And so definitely want to refer the committee back to that report as you went over these numbers, kind of looking to Monterey County as a case study, I think would be important. Thank you.
Thank you. Looking virtually, seeing no hands raised, and to the podium, no one at the podium. That concludes public comment on this item, and I believe takes us to our lunch hour. The time is now 12:07, and we will reconvene at 12:40. Thank you.
I will ask for us to confirm the roll.
Thank you. Dr. Sandra Hernandez.
Here.
Secretary Kim Johnson.
That's it.
Richard Kroenig.
Here.
Ian Lewis.
Present.
Dr. Richard Pan. Don Moltz.
He should be right back. We'll acknowledge him as soon as he returns.
Great.
Thank you so much. We are going to move now into item 5C. This is the spending target enforcement, continued spending target penalty discussion. Vishal and CJ Howard will take us through this item. I'll turn it over to you. Thank you.
Thank you, Chair Johnson. So we'll continue our discussion of spending target penalties. We introduced this topic at the April meeting, discussed it at the May meeting, and on the next slide, we'll cover today's topics.
And I will just acknowledge that Don is here. We just did the roll. No, that's fine. Thank you.
So items for today's discussion. So this includes, can OCA assess penalties if an entity does not meet their performance improvement plan or PIP milestones? This is a topic that came up at the last two board meetings, so we'll provide clarity on this today. We'll also provide clarification on a spending target penalty justification factor, the non-federal share for Medi-Cal reimbursement. We'll review and discuss spending target enforcement penalty setting process. We'll discuss what the range of spending target penalties should be. And lastly, we'll discuss what the procedural penalties for violations described under Health and Safety Code section 127502.5 H1 should be. And then items for future discussion. So at a future meeting, we'll have a board vote for spending target penalty scope, range, and justification factors for Health and Safety Code section 127502.5 subdivision A and subdivision D. We'll also have a board vote for procedural penalties, scope, range, and justification factors for Health and Safety Code section 127502.5 subdivision H, paragraph 1. And we'll discuss draft regulations for spending target enforcement at a future meeting. Next slide. So our first topic is whether OCA can assess penalties against an entity for missing performance improvement plan milestones prior to the end of the PIP's implementation period. Again, this is a topic we discussed at prior board meetings and board members asked for clarity. So our answer is yes, OCA could assess penalties against an entity for missing performance improvement plan milestones. This would be at the discretion of the director, and we'll cover more about what those penalties could look like in later slides. Next, we want to highlight a penalty justification factor that is mentioned in statute. When determining administrative penalty amounts, OCA would, in accordance with statute, consider provision of non-federal share. And here we see excerpts from statute under section 127502.5 subdivision D, paragraph 3. It says the director may consider related provision of non-federal share determined to be appropriate by the director of the Department of Healthcare Services. And here I want to remind the board that OCA will be consulting with relevant regulators prior to taking enforcement actions. And this is where the DHCS director would provide guidance to OCA on non-federal share. And on the next slides, you'll see what we've added consideration of non-federal share to the list of penalty justification factors. So next is a review of OCA's recommended approach for calculating spending target penalties. We covered this at the May meeting. Under step 1, OCA would calculate penalties that are initially commensurate with the degree to which the entity exceeded the spending target. Initially commensurate is the difference between an entity's actual spending growth and what the growth would have been had the entity met the target. Step 2, OCA would consider a variety of penalty justification factors that could result in an increased or decreased final penalty amount. Penalty justification factors listed in statute include nature, number, and gravity of offenses, the fiscal condition and market impact of the entity, and consideration of provision of non-federal share. Other potential adjustment factors include input from other state agencies, other factors approved by the board, and escalating amounts for repeated failure to meet targets. And these would apply to any penalty, including spending target penalties and procedural penalties that we'll discuss in later slides. This slide reviews what we've shared before. It shows penalty justification factors and a non-exhaustive list of potential examples of what each factor could include on a case-by-case basis. For nature, number, and gravity of offenses, which is what is listed in statute, OCA could consider excess growth beyond the state average, or excess growth that was an extreme outlier, excess growth due to investments in primary care, and more. For the physical condition of the healthcare entity, OCA could consider bankruptcies or other legal proceedings, whether the proposed penalty negatively impacts the entity's financial standing with other state and federal regulators, and more. And last, for the market impact of the entity, OCA could consider if the entity's share of total covered lives statewide is significant or greater than the average, the entity's impact on spending in its county, and more. So now we'll pause for board discussion, and I want to note the green arrows on the slide indicate this is a discussion item that will eventually lead to a board decision. We have made some clarifications today about the recommended approach. So we again are looking for feedback on the proposed penalty structure. So specifically, a penalty structure that calculates penalties that are initially commensurate and then makes adjustments based on a variety of factors. Penalty justification factors would be those listed in Health and Safety Code section 12750.2.5 subdivision D, as listed on the slide. And again, these justification factors would apply to any penalty, including spending target penalties and procedural penalties that we'll discuss in later slides. So I'll turn it over to Chair Johnson.
Thank you very much. And just appreciating in a couple of places here the statutory references. It is helpful, I think, for everyone's context to really understand what's in the law and where we have additional input in this place. So appreciate that structure of the presentation. Board members, feedback, questions, comments. Andrea.
So I'm not sure I quite understand how you're thinking about the non-federal share as it relates to other agencies and their input into that. Can you just, how would that work?
Yeah. So the non-federal share, it's a requirement in statute for, if we're going to assess a penalty in a healthcare entity, typically a provider, like such as a hospital, puts up the non-federal share. It's something we could consider, potentially deducting or adjusting the penalty.
So if the hospital puts up the non-federal share?
Yes.
Right. So we have public hospitals who have to put up the non-federal share, and so we would we would ask the hospital for that data and understand the situation from them, and could validate with the HCS. But that is the provision of the statute requires us to look at that piece.
That's correct. Yeah. Yeah, we would consult with DHCS. Yeah.
I'm supportive of the general approach that you've laid out.
Okay, I could move along to the next set of slides. So taking us to spending target penalty range, we have a couple of excerpts from the statute on the slide. The first says the board shall approve the scope and range of administrative penalties and the penalty justification factors for assessing penalties. And that's why we have green arrows on this slide, because this will be part of an eventual vote on spending target, penalty scope, range, and penalty justification factors. The second excerpt says that OCA may assess escalating penalties that exceed the initially commensurate penalties. Two important considerations for the range of spending target penalties are the range should give OCA the flexibility to lower or increase the penalty during step 2 of the proposed spending target penalty calculation from the initially commensurate penalty. Escalating penalties must be large enough to deter future non-compliance. With those considerations in mind, OCA recommends a percentage-based range of up to 125% of the initially commensurate excess growth. A percentage instead of a fixed dollar limit offers a range of penalty amounts depending on the level of excess spending over the target. A percentage above 100% allows for escalating penalties as required in the law. A limit of 125% will create a penalty large enough to deter future non-compliance. The range allows the office to adjust the penalty below 100% of the initially commensurate amount based on penalty justification factors. And on the next slide, we'll see some examples of what the maximum range would look like.
Just curious about why 125% is the magic number. You say that it's adequate to deter. Is that based on something or?
So escalating penalties is, there's not that many examples from other state government agencies that we could draw upon. So we do think that the 100% penalty is substantial and sends a strong signal to encourage compliance. But because the law requires escalating penalties, so this is the percentage that we're recommending. We could always revisit it if it in practice, if it doesn't create the compliance that we're seeking. But we're open to hearing board feedback on alternatives.
I mean, I'm assuming that the concern is that you get into a situation where an entity just makes a business decision that factoring in the cost of the penalty is from a business perspective makes the most sense, right? And that you're trying to, that part of what goes into what undermine or what is behind the ability to increase that is you want to be in a position to address that with higher penalties so that doesn't happen. I just worry that if you pick an arbitrary amount and say can't go above this, it undercuts the flexibility that you have in the law to increase it if that's what's going on. Because that could go on at 100%, it could go on at 70%, it could go on at 150%. We don't have any idea, or I don't think we have any idea, and there's no reason to believe there's a magic number there. So it seems like maintaining the ability to address that situation speaks to not having a cap per se.
I want to be clear that we're not assuming any type of behavior. We're not assuming that entities would necessarily treat this as a cost of doing business. We hope that entities are taking it seriously and will be responsive. And as Vishal stated, the statute is clear that we have to allow for escalating penalties. And so we did want to put out a percentage for the board to respond to. And the next slide, you may know, shows some of the percentages that the board could consider. But the board will have to vote on range and scope of penalties. And we do think it makes sense to do it as a percentage because that takes into account the scale of the extent to which the entity exceeded the target. But it looked like your colleague was having some reaction.
Just with the base penalty being commensurate with the difference between the target and spending, that could be a large number, and I do think that in and of itself, I don't think entities are going to decide that that's an okay cost of doing business. So I'm not too worried about the 125 versus 150 versus 110. I mean, the 100 is already, I think, going to be enough to, assuming the covered entities actually think that they will have to pay that as opposed to going to court or getting the legislature to change it, then that's a big number to begin with.
Yeah, I don't disagree that that's a significant number. And I didn't want to imply that entities are going to in fact do this. I was suggesting that seems like from my perspective, is the primary concern that you're trying to protect against and allowing for that flexibility. Maybe there are other things that underlie the flexibility. I just wonder, I mean, if we have to set a percentage above 100, we have to set a percentage, but I guess I was partially asking the question, do we in fact have to set a percentage cap, or can we just build the flexibility so that you can adapt in the event that that's the situation you find yourself in?
Well, the statute does talk about a range, so that does imply a maximum. So that's why we're proposing the percentage 125.
But I wondered, sort of parallel to that, you're not proposing a minimum, at least that I saw, and do we not need to propose a minimum, or the minimum is 0 or 0.
It's up to 125. So these will be kind of fact specific circumstances that we'll have to assess. Those penalty justification factors, if the fiscal condition of the entity, may not warrant a 100% penalty, we could reduce it. It could be reduced, down below 100%.
Yeah, effectively, Rick, you're right. We're not recommending a particular percentage amount, and we do note that we would have the ability to decrease it from the 100% initially commensurate with, as stated in the statute.
And is the thought in response to Don's question that it's okay not to propose a minimum because it's okay to leave that open, but we need to propose a maximum?
I mean, to answer your question, if we're silent on it, then yes, the minimum would be 0 effectively.
Yeah, Don just asked my question, but while we're on the topic, I'd say that, the 125% seems like an appropriate level to start with. I think my thinking might change if the PIPs don't reset to what the original baseline trend should have been, which I know is a topic we'll come back to at a later date. But in previous meetings, we've gone back and forth about what we do there. So I think that's the one case where I'd be concerned that the 125% isn't adequate.
I think if the statute is asking for a range and we could envision a scenario where it'd be less than 100%, we ought to be clear about that. And so maybe what we say is the range is anywhere from 0, I don't know what scenario that would be, but potentially up to 125%. So that gives a lot of flexibility. I don't know that 125% is enough flexibility, but I think if we're going to say a range, I would do the whole piece.
Could move us along, just to, for the benefit of the public, that so this is here in the left column, we have some example commensurate penalties. These are examples of what the initially commensurate penalties would have looked like in 2023, if 2023 had been an enforceable year. These are at the aggregate parent company level for health plans. The smallest was 4 million, and in the columns in the right, we see what the penalty would be if it were increased to 115 or 125 or 150, based upon application of penalty justification factors. I want to note that the example penalties in the left column are not associated with the size of the plan. They are associated with the degree to which the entity exceeded the target. And again, OCA's recommendation is a range of up to 125.
Take public comment here.
Yeah, since the board has already discussed, we could break for public comment.
So we just, for everyone tracking at home or here in the room, we are still on this conversation related to spending target enforcement, but what we're going to do is have 2 public comment periods. So in this public comment period, we're going to ask you if you have comments related to what has been presented to date, which again is the range, as well as the components around the structure. So if you have public comments on those 2 pieces, we welcome that now. If it's about other components of this conversation, this agenda item, we'll ask you to wait until we have some additional conversation.
All right, this opens the public comment period. If you're attending virtually, please raise your hand. In the room, please step to the podium. Looking to the podium, go ahead.
Beth Capel for Health Access California. We want to say again that what is exorbitant today is the cost of healthcare and what consumers are paying in terms of premiums, deductibles, and copays and coinsurance to get the care they need, and how many people are not getting care when they should because of those exorbitant costs. We support commensurate penalties consistent with California law. We oppose using the laws that apply to other states that have very modest penalties or none at all. We will also note that any penalties for exceeding the spending target come at the end of a very lengthy enforcement process with many opportunities for remediation and for people to come into alignment with the target. We support limiting the penalty justification to those enumerated in California law, including nature, number, and gravity of offense, the fiscal condition of the entity writ large, including any subsidiaries and affiliates, as well as any system that they're part of, the market impact of the entity, and the Medi-Cal non-federal share that is also recognized in the law. We oppose penalty justification factors that are not enumerated in California law, especially those factors that should be considered earlier in the enforcement process. There are suggestions that we double count by first discounting, exceeding the target, and then discounting the penalty. Somebody tried to edit my stuff to say this was double exempting, but it's either way, it's counting twice. We support basing the range on a percentage of the commensurate penalties, in part because the range of entities subject to the penalties will vary greatly. We have the same questions about 125% that the board members have, and would want to make sure that a future board could revisit that if the need arose. And again, what is exorbitant today is the cost of healthcare that consumers are suffering from. Thank you.
Thank you. Appreciating that we have a number of folks that want to make public comment now, reminding everybody to keep your comments to 2 minutes. And we do have 6 hands raised virtually, so I'm going to go to our first hand raised virtual. Neil, go ahead.
Hello, this is Neil Clark on behalf of the United Hospital Association and its member hospitals. I want to thank you for the opportunity to comment today. Hospitals share the goal of improving affordability for patients, but the enforcement framework needs to be workable, balanced, and grounded in real-world conditions. State law envisions a meaningful, collaborative remediation process, and not punitive measures that jeopardize access to care. The proposed penalties are far beyond what other states impose, and for some hospitals, it could exceed operating margins from patient care. At a minimum, enforcement must account for financial condition, factors outside a hospital's control, and reliable multi-year data. Californians need an approach that advances affordability while preserving access to hospital care in every community. Thank you.
Thank you. Going back to the podium, go ahead.
Hi, good afternoon. Anate Millers on behalf of the California Association of Health Plans. CAP appreciates OCA's ongoing work to promote affordability and spending accountability. However, as these discussions on penalties continue and amplify, I wanted to briefly reiterate a concern we previously raised regarding the Managed Care Organization or MCO tax. Now that the California legislature has approved the proposal, plans are facing a new and significant cost obligation that will directly affect commercial coverage. Based on information shared by our member plans, the increased MCO tax is expected to consume a substantial portion of California's 3.5% spending target before accounting for other medical cost drivers, utilization trends, prescription drug costs, provider contracting pressures, or investments that support quality and access. The MCO tax is particularly relevant to OCA's work because taxes and fees are reflected within OCA's spending framework. As a result, this policy change will have real implications for affordability metrics and spending target performance. As the board continues its discussions regarding spending target enforcement and penalty frameworks, we encourage OCA to recognize that some spending pressures originate outside of the control of health plans and are the result of public policy decisions rather than underlying changes in healthcare utilization or efficiency. We appreciate OCA's continued focus on affordability and encourage ongoing consideration of how externally imposed costs, including the MCO tax, interact with spending target expectations and enforcement policies. Thank you.
Thank you. Looking virtually, Myra, go ahead.
This is Mara Morton with the California Children's Hospital Association. I appreciate the opportunity to comment on this issue. Children's hospitals share OCA's goal of improving affordability and support accountability for excessive spending growth. A well-defined enforcement framework should distinguish between sustained cost growth and normal year-to-year variation and avoid imposing penalties that could jeopardize patient access. For children's hospitals, annual trends can be heavily influenced by factors outside our control and experience significant variation due to things like newly approved gene therapy costing millions of dollars per patient or a one-time increase in pediatric transplant volume. Because specialized pediatric services are concentrated among a handful of providers, these circumstances can significantly affect annual spending calculations. We join the California Hospital Association in urging OCA to evaluate performance over multiple years to provide hospitals a meaningful opportunity to explain unusual circumstances and prioritize technical assistance and performance improvement before considering penalties. We are also very concerned about the magnitude of the penalties being considered. Modeling the 100% penalties using 2023 commercial data shows that some children's hospitals would have faced penalties exceeding $50 million, with one even exceeding $117 million for the year. In several cases, these penalties would have entirely eliminated the hospital's operating margin or deepened an existing loss for the year. For children's hospitals seeking to maintain essential pediatric tertiary services, penalties of this magnitude would not simply be a financial consequence, they would pose an existential threat to access. Other states, including Massachusetts, have demonstrated that spending targets can promote accountability through transparency, performance improvement planning, and collaborative oversight, with penalties functioning as a backstop rather than the centerpiece of the framework. As OCA moves forward toward formal rulemaking, we urge the board to adopt a more measured enforcement framework, one that promotes accountability through transparency, technical assistance, and performance improvement, while recognizing the unique circumstances facing providers that care for California's sickest children. Thank you.
Thank you. Going to the podium. No, press it till there you go.
Chair Johnson, Director Landsberg, members of the board, thank you. I'm Susan Green, the CFO of Sharp Healthcare, San Diego's largest provider and largest Medi-Cal provider. Let me be direct. The penalty framework before you will not make healthcare more affordable. It will make it less available. And I don't say that from theory, I say it from experience. Before joining Sharp in 24, I spent decades in Massachusetts in finance leadership, including at Tufts Medicine, from the day the Health Policy Commission was created in 2012. I lived through every cost benchmark year. the model that OCA cites. So hear this clearly, what California is proposing is something much more punitive. In Massachusetts, the maximum penalty was $500,000, and it was only imposed if you failed to implement the performance improvement plan, not exceeding the benchmark. In 14 years, Massachusetts never imposed a penalty on a single hospital. OCA's proposal would calculate penalties on a full dollar difference between actual and allowed costs. For Sharp, on the illustrative model, that was $59 million. And even in this restrained approach, the Massachusetts healthcare system is in crisis. In 2024, median hospital operating margins were negative 2%. Only 39% of hospitals finished in the black. Tufts Medicine, where I serve, lost $171 million after $400 million the year before. And Steward Healthcare, investor-owned, declared bankruptcy, and 10 hospitals had to be taken over. The legislature had to rush to $234 million emergency bailout of that and $417 million the year before. California now proposes to leapfrog that penalty structure at the exact moment when hospitals face millions or trillions of dollars in Medicaid cuts under H.R. 1 and billions in Medi-Cal reductions and over 3.4 million Californians losing coverage. Meanwhile, Sharp delivers $2 million every single day in community benefit. We absorb $742 million of uncompensated care. We're the only delivery service in San Diego's South Bay, and we receive transports from the Mexican border. We serve 35% of the Medi-Cal population. My ask is straightforward. Align California's penalty structure with proportionality and remediation first. I've seen what financial destabilization does to hospitals in the communities of color, low-income, border populations. They'll bear the heaviest burden. Thank you.
Thank you. Reminding everyone to keep your comments to 2 minutes as possible. And looking virtually, Angus, I see your hand raised. Go ahead.
Good afternoon. Thank you for the opportunity to provide input today. I'm Angus Cochran from Washington Health, an independent district hospital located in Fremont. So I'm providing you a perspective this morning from a standalone public hospital in one of the most expensive cost environments in the nation, the Bay Area. Washington submitted written comment which details our concerns with the penalty structure that the board is contemplating. We urge the OCA board to establish regulations that balance affordability with access to care. We truly believe that the penalties of the magnitude that are being discussed today could threaten our existence as an independent entity. And that will simply reduce the care available to residents in Southern Alameda County. We appreciate the earlier discussion that penalties could be adjusted based on a variety of factors. Nevertheless, this one-size-fits-all enforcement approach will have detrimental impacts on our ability to sustain access to high-quality, equitable care and a stable workforce, priorities that I believe we share with OCA. We also want to point out that we feel it's fundamentally inequitable that certain public hospitals are exempt from OCA oversight, which effectively shields them from fines. This creates an inequitable, arbitrary, and inconsistent system in California, especially at the level of fines that the board is planning. You've heard us express the opinion before that Washington Health does not meet the criteria for inclusion on a high-cost outlier hospital list. Yet here we are, applying these fines to a public hospital like ours while exempting other public hospitals is fundamentally inconsistent. Both operate with taxpayer support, and there's no rational basis for treating them differently. In closing, I just want to remind OCA that the enforcement framework that OCA adopts will directly determine whether Washington Health can continue to be there for the residents of Southern Alameda County who depend on us for life-saving health care. Thank you.
Thank you. Back to the podium.
Hi, good afternoon. Thank you for the opportunity to speak today. My name is Hannah Baker, Vice President of Payer Strategy at Sharp Healthcare. And as Susan mentioned, Sharp serves approximately 1 million patients across San Diego County, and we're deeply committed to providing accessible, high-quality care to all patients we serve. Today, I want to focus on a central issue that must be addressed in any affordability framework, cost shifting, and the underlying structural imbalances that drives it. Cost shifting is real and measurable. There's been discussion suggesting that cost shifting is theoretical. And from our perspective and based on our data, it is very real and very measurable. At SHARP, we see consistent underfunding in public programs, particularly Medi-Cal. As an example, in 2025, for every dollar in revenue, Medi-Cal revenue, we spend $1.15 in cost, resulting in a negative margin even before overhead costs are considered. Additionally, our capitated lines of business where we are fully at risk both financially and clinically on both the commercial and Medicare Advantage lines of business show overall negative net income, reinforcing the issue is systemic, not episodic. When providers are reimbursed below the cost of care, those losses do not disappear. They must be absorbed elsewhere in the system. Cost shifting is fundamentally tied to payer mix. And SHARP operates in a payer mix environment that includes all lines of business, commercial, Medicare, Medicare Advantage, Medi-Cal, and risk-based and fee-for-service. Medi-Cal and certain capitated arrangements consistently underperform financially, while commercial contracts often carry a disproportionate share of financial sustainability. This widening gap amplifies the need to offset losses, not because providers are increasing prices arbitrarily, but because the financing structure requires it. Any analysis of hospital spending that does not explicitly incorporate payer mix risks misinterpreting cost shifting as cost growth.
2 minutes.
SHARP supports OCA's goal of improving affordability. However, to ensure the framework reflects real systemic dynamics, we respectfully recommend explicitly incorporating payer mix and Medi-Cal shortfalls into spending assessments, translate non-federal share factor into quantifiable offsets, recognizing cost shifting as a structural reality, not a theoretical construct, and align penalties with controllable factors. Thank you.
Thank you. Looking virtually, Janice, I see your hand raised. Go ahead.
Thank you, Janice Rocco, on behalf of the California Medical Association. Enforcement of the law is important. Penalties that exceed operating earnings will harm access to care, so that needs to be an important consideration here. The staff recommendation is to calculate penalties that are initially commensurate with the degree to which the entity exceeded the cost target. Starting there in the initial years of enforcement, the very first year an entity might be subject to a fine under the statute, is a proposed approach that's aggressive and potentially counterproductive. The staff recommendation is to start the financial penalties as high as the statute allows and then potentially lower them over time. Some of the healthcare entities in question may not exist in those future years if OCA pursues this approach. As CHA pointed out in its comment letter, this is 20 times the penalty approach that Oregon has taken. And as one of the previous speakers talked about Massachusetts, their approach is escalating fines if an entity is not making improvement, and their cap is far lower than what is contemplated by the OCA staff proposal. If you take an overly aggressive approach, you will likely see some of the lower cost, smaller healthcare entities closing and others being acquired by larger, higher cost entities. Enforcement penalties need to be well thought out and not such that they drive market consolidation that will increase costs and decrease access to care. Doing otherwise is not consistent with the law. Thank you.
Thank you. Back to the podium.
Thank you very much, Secretary Johnson and members of the board. My name is Amber Turvroot here on behalf of Scripps Health. Scripps urges the board to reject the penalty framework until critical flaws are fixed. This framework that OCA has published is producing wildly incorrect data. OCA's data sets should suggest that Scripps commercial rates across its hospitals went down as much as 4.8% and up as much as 30.1%. Not only is this impossible under our contracts, because they're capped at, our increases are capped at 5% at most in 2023, but it's physically impossible as our commercial contracts are identical across every Scripps hospital. Further, your data suggests Medicare increased Scripps reimbursement by 11%, and our Medi-Cal rates at Scripps Green increased by 55% in 2023. Again, this is impossible. Commercial contracts across Scripps are identical. Medicare and Medi-Cal reimbursement is run on the same formula across all of our hospitals, and yet your methodology suggests payment schemes that are diametrically opposed to our reality. Your methodology produces these types of results anytime a hospital has a one-time event in revenue, a legal settlement, a cyber attack recovery, or even cyclical flows in operations. anything outside of year-over-year pricing. The methodology has no mechanism to separate real rate changes from all of those events. Apply OCA's penalty formula to this methodology's output at 100% for that year, and you get a roughly $160 million penalty against Scripps Health in a year in which we lost $37 million. If OCA penalizes Scripps by this amount, we would have lost $200 million in this single year. This is not a cost of doing business. If this occurs, our hospitals will close. This will not make healthcare cheaper, but you'll be making the healthcare of Californians undoubtedly worse while inflating insurer profits. We cannot ignore these facts. I recognize I'm low on time. I'll submit more information, but we really look forward to working with you. We stand ready to assist and be a part of this solution. Thank you.
Thank you. Going virtually, Jamie, go ahead.
Hi, this is Jamie Godwin speaking again on behalf of the California Association of Public Hospitals and Health Systems. California's public hospitals and health systems support OCA's goals to make healthcare more affordable. However, we have significant concerns with the proposed framework on financial penalties and enforced spending target performance. Public healthcare systems are facing nearly $4 billion in cuts as a result of H.R. 1 and changes to Medi-Cal coverage and payments that were recently enacted, as well as additional ones being considered through the budget process this year. As a result, some public healthcare systems are contemplating service line reductions, staff layoffs, and potentially other larger changes like facility closures. While we appreciate that there are some considerations for lower penalties compared to the initial proposal, the level of penalties that are being considered continues to be deeply troubling, and penalties reaching 125% of the difference between targeted and actual spending growth risk further destabilizing public health care system facilities in California. This penalty structure could lead to even more widespread disruptions and loss to access for patients. We also appreciate the clarification that OCA will account for the source of the non-federal share of Medi-Cal payments as a penalty justification factor. We further recommend that OCA develop clearer policies around Medi-Cal, including how self-financing is accounted for in the spending target performance measurement, and when growth is above the target is permissible to protect and promote access to care in the safety net and to achieve policy goals. We support the consideration of Oregon's approach to excess spending penalties, and our concerns around the measurement of Medi-Cal revenue are outlined in our recent comment letter to OCA and the board. We look forward to any opportunities to partner on developing solutions. Thank you for your consideration.
Thank you. Back to the podium.
Good afternoon, Secretary Johnson, Director Landsberg, members of the board and staff. Alfredo Medina here with Manat Phillips & Phillips on behalf of Cedars-Sinai Health System. Cedars-Sinai supports the goal of improving healthcare affordability and expanding access to high-quality care. However, we have serious concerns with the enforcement framework that could impose extraordinary financial penalties on hospitals before the rules, methodologies, and compliance expectations are fully clear. Hospitals are operating in an increasingly difficult environment. They are absorbing rising labor costs, escalating pharmaceutical expenses, inflationary pressures, workforce shortages, expanding regulatory mandates, and significant federal funding reductions. At the same time, much of the hospital revenues are tied to Medicare and Medi-Cal reimbursements, which often do not cover the actual cost of care. Against this backdrop, penalties that could reach tens of or even hundreds of millions of dollars would not improve affordability for patients. They would divert resources away from patient care, workforce development, research, community benefit programs, and access initiatives. Finally, academic medical centers like Cedars-Sinai play a unique role. They care for some of the most medically complex patients and provide specialized services that few institutions can offer. The enforcement framework must account for that reality. We respectfully urge the board to adopt a thoughtful and reasonable approach, finalize the transparent methodology, use multiple years of data, recognize factors beyond hospitals' control, provide meaningful opportunities for corrective action, and ensure that penalties are proportionate to demonstrated and sustained noncompliance. We appreciate the time and thank you for the consideration.
Thank you. Going virtually, Connie, go ahead.
Good afternoon, Chair Johnson and members of the board. Connie Delgado with the District Hospital Leadership Forum, representing California's 33 district and municipal hospitals. DHLF supports improving affordability, but OCA's enforcement framework must also protect access to care. Many district hospitals are rural, critical access, and safety net providers operating on thin margins. Even a $4 million penalty could force some hospitals to reduce staffing, cut services, close clinics, or threaten operations. Before penalties are considered, hospitals need clear rules, validated data, and a meaningful opportunity to explain spending growth. OCA should use a collaborative performance improvement process that accounts for multiple years of data, payer and service mix, Medi-Cal supplemental payments, and factors outside a hospital's control. A penalty framework that destabilizes essential community hospitals will not make care more affordable. It will reduce access in the communities with the fewest alternatives. Thank you for the opportunity to comment.
Thank you. And back to the podium.
Good afternoon, Stacy Bratcher on behalf of Cottage Health, headquartered in Santa Barbara, California. Thank you for the opportunity. I want to say it's hard to sit and see you all considering penalties of up to 125% against hospitals, especially as we're all facing the impacts of the One Big Beautiful Bill. In Santa Barbara, we estimate that that will take $40 million out of our operating funds. With those sorts of cuts, there's no way we can continue to provide the low margin or no margin services such as pediatrics, labor and delivery, psychiatry. Further complicating matters in Santa Barbara is that there is no public hospital. So our hospitals are the safety net. You received letters from our County Board of Supervisors showing that they are also concerned. They are closing many of their services and they are relying on Cottage Health to fill the gap. If we are fined, penalized up to $30+ million in addition to the Big Beautiful Bill cuts, I don't know that we'll be able to continue to provide services. We estimate our labor costs at an average of $174,000 per employee. That includes salary and benefits. When my daughter got her appendix out at Cottage, and it was lovely to be in our hospital and be a customer for a change, I counted 11 staff members that saw her before we got to surgery. Those are people who may or may not have jobs if we are further penalized by our state and federal governments. You all really need to think about how expensive it is for hospitals to deliver care. Our drug costs are up 7%. We have no ability to control that. We are at the whim of the pharmaceutical manufacturers. We're doing everything we can to reduce costs and offer free and reduced care. Over the last 3 years, we provided $43 million of charity and discounted care. I would really urge you to think closely and carefully about how penalties would affect hospitals. Thank you.
Thank you. Virtually, Erin, I see your hand raised. Go ahead.
Good afternoon. I'm Erin Evans with the County of Santa Clara. The county and its public healthcare system, Santa Clara Valley Healthcare, appreciate the opportunity to comment on the proposed financial penalties for spending target performance. Santa Clara Valley Healthcare operates the largest public hospital system in Northern California, serving 460,000 patients through 4 hospitals and 15 comprehensive health centers. Our system has grown significantly over the decade. The county has purchased 3 hospitals since 2019 to ensure our communities have access. 2 were in bankruptcy, and the 2025 purchase of Regional Medical Center was initiated after services were downgraded or closed. Our community increasingly relies on our system, especially as people lose coverage due to HR1 and changes to the state-only Medi-Cal coverage. It's critical that our community health system not be penalized for efforts to secure revenue necessary to maintain the services that we need. Once HR1 federal and state funding cuts are fully implemented, the county anticipates an annual $1 billion loss. With the magnitude of these funding losses, we're taking every action possible to develop budget solutions and efficiencies, yet this is not enough to fill the gap. So we will be faced, with increasing revenue and scaling back services to maintain access to care. The penalty structure that's proposed could further destabilize public healthcare systems like ours, putting care at risk for the communities we serve. Given these concerns, Santa Clara urges your board to consider alternative approaches to the penalty framework like what has been adopted by Oregon. Thank you.
Thank you. To the podium.
Good afternoon. Can everyone hear me? Thank you very much, Secretary Johnson, Director Landsberg, board members, staff members. My name is Helen Herrera. I am the Director of Advocacy and Health Equity for St. Agnes Medical Center in Fresno, California, part of Trinity Health System of Care across 25 states. And I'm here in support of our California hospitals, my colleagues here, and the state that we find our communities in. As hospitals prepare for the significant fiscal impacts, which we're all hearing, one right after another under OB3, one big, beautiful bill, HR1, what the cost will be for St. Agnes would be $53 million over a period of 10 years once it's fully implemented. Today, and I apologize, lost my place. Today, I'm urging OCA to recognize that the current approach purposely leaves out the strong voice of hospitals. What is needed is thoughtful, inclusive oversight that is built on true partnership between OCA and California hospitals. An equal partnership is the only path forward to ensure patients do not experience diminished access to care as hospitals work to meet both state performance improvement expectations along with evolving federal CMS requirements. OCA has an opportunity right now to course correct. The current enforcement process is not sustainable, certainly not for St. Agnes and our 96 years in Fresno and serving Central Valley. It will wipe us out. By taking steps to partner, to collaborate, to be accountable and transparent, we can strengthen our community's health status. More importantly, we can renew our partnership, deliver equitable and high quality care for the Central Valley and Californians. Thank you for your time.
Thank you. Going back virtually, Pooja, I see your hand raised. Pooja, you're unmuted on our end. You might need to unmute on yours. It should be in the top right-hand corner of the screen. If for some reason that mic button is grayed out, two options. You could log off and log back on and see if that makes it work, or also dial in at the number on today's agenda and press *5 to raise your hand. I will also come back around to you, but for now I'll go back to the podium.
Good afternoon, board and staff. Ben Johnson from the California Hospital Association. Organizations representing over 100 hospitals have written or commented today to share their grave concerns with OCA's direction on penalties and its overall enforcement process, which deviates from state law, falls short of the legislature's intent to create a collaborative and progressive enforcement process, and risks finding hospitals at levels that threaten their very existence. Hospital care not being there when patients need it is not the path to improved healthcare affordability. We ask for a number of critical but sensible changes to OCA's enforcement framework. First, validate the hospital spending measurement framework to ensure missing data is not driving enforcement decisions that will divert enormous attention and resources. Two, assess hospitals on a multi-year basis to avoid arbitrary enforcement decisions based on random fluctuations in measured hospital spending, which you have all seen is extraordinarily volatile and shows hospitals simply cycling in and out of exceeding the target each year. Three, clarify what it means to be accountable against the spending targets. Pushing hospitals into the enforcement process for exceeding the target on any payer or service line would mean nearly every hospital every year would have to go back and forth with OCA on the reasons for their cost growth, receive TA, face uncertainty on whether their organization would be subject to a PIP, and potentially be subject to penalties even if they overall stayed under the target. This is unworkable from the office's perspective and again diverts resources that should support patient care and efficient administration both of hospitals and of our state operations activities. To fix this, OCA must conjoin outpatient and inpatient spending into a single measure and only enter enforcement against hospitals that exceed the target on the commercial and all-payer lines. 4, OCA must give hospitals an opportunity to improve their spending trends under a PIP according to flexible strategies that work for their organizations rather than rushing to penalties or imposing one-size-fits-all strategies. State law is clear. Enforcement must follow the law's progressive process in all cases except where there is egregious noncompliance. 5, set penalty amounts that are within the bounds of reason. The starting penalties would have exceeded the 3-year cumulative operating earnings of 1/4 of the state's hospitals in 2023. They are 20 times higher than the next closest state's penalties, and they are not ultimately consistent with healthcare sustainability and violate the legislature's directive to promote affordability, but not at the expense of access, quality, and workforce stability. We urge the board to set reasonable limits that protect access to care and avoid the need for massive, unpredictable downward adjustments,
3 minutes.
bring penalties down to practicable levels. OCA should look at its peer state for examples of a far more workable penalty structure that sets clear standards and incentivizes compliance without threatening the financial viability of its regulated entities. We lay out the why these changes are essential in our recent letters to the board, and thank you for your consideration.
Thank you. Looking back virtually and reminding everyone to keep your comments to 2 minutes. Manahar, I see your hand raised. Go ahead.
Hi, good afternoon, members of the board. Manohar Sukumar with the Health Law Unit of Public Law Center, which provides free legal services and assistance with health access issues for low-income Orange County residents. As a consumer advocate, I see firsthand how rising healthcare costs affect California families every day. Every year, consumers are facing higher premiums, deductibles, co-pays, and other out-of-pocket costs, often forcing them to make difficult choices about whether to seek care. The annual spending target is only helpful if there are strong consequences for exceeding it. Large hospital systems and insurers have significant market power, and penalties must be strong enough to create real incentives to control spending growth and comply with the law. Weak penalties will simply be absorbed as a cost of doing business, and it will not protect the consumers. We also support the procedural penalties for entities that fail to provide complete and accurate information. OCA cannot effectively monitor healthcare affordability or enforce spending targets without having reliable data. Californians need a healthcare system that is affordable and accountable. Strong enforcement penalties are an essential part of achieving that goal. Thank you for the opportunity to comment today.
Thank you. Back to the podium.
Thank you. Good afternoon, Chair Johnson and members of the board. Thank you for the opportunity to comment today. I'm Mindy Maschmeyer, here to represent Community Hospital of the Monterey Peninsula, which is part of Montage Health. I want to start by acknowledging that improving affordability is a goal that we all share. Patients, providers, and policymakers alike want a system that is sustainable and accessible. However, the current direction raises serious concerns. The methodology used to establish these spending targets is fundamentally flawed. It does not adequately account for real-world cost drivers, particularly labor, pharmaceuticals, and supplies that are largely outside of hospitals' control. While the inputs are incomplete, the conclusions and the policy decisions based on them risk being misguided. It is critical to distinguish between individual hospitals and large healthcare systems. Community hospitals operate with far fewer resources and much thinner margins. Montage Health's 2026 budgeted operating margin is less than 1%, and our community hospitals' payer mix is 80% governmental. Treating all entities the same ignores these differences and disproportionately threatens the state stability of smaller, locally focused providers that communities rely on. While affordability is an important goal, it must be addressed comprehensively. Hospitals are only one part of a much larger ecosystem. Pharmaceutical companies, insurers, and other actors play a significant role in driving costs. Local government factors also influence care delivery. Monterey faces budget constraints. Police often bring or leave social work-related cases at our emergency department, and ambulance services are managed at the county level. In addition, external post-acute providers, including skilled nursing facilities, home health, and hospice, all play a critical role in determining our ability to discharge patients efficiently. Focusing enforcement primarily on hospitals risks targeting what is simply the most visible. Finally, the timing of these proposals is deeply concerning. With the significant federal cuts and financial pressures already impacting providers, moving forward with potentially punitive measures at this moment feels profoundly tone deaf. Hospitals are already making difficult decisions about services, staffing, and investments. We urge OCA to take a more thoughtful, balanced, and collaborative approach, one that assures affordability while preserving access to care for the communities we serve. Thank you.
Thank you. Virtually, Celine, I see your hand raised. Go ahead.
Hello, good afternoon, Chair Johnson, members of the board. Celine Betancourt with the California Pan-Ethnic Health Network. CPEN supports strong penalties based on California law, which requires a multi-step enforcement process before the director can even consider imposing financial penalties for exceeding the cost growth target. With respect to the adjustment factors in step 2, we support penalties above 100% to encourage large hospitals and insurers to slow spending growth and meet the targets. We are opposed to adjustment factors to penalties that lack statutory authority. Consumers are being squeezed by high healthcare costs. Premiums, deductibles, and co-pays are adding up and pushing families to the breaking point. More than 8 in 10 Californians say that making healthcare affordable is extremely or very important priority for state decision makers to address in 2026. We know that a quarter of every dollar spent in healthcare has no value for patients. This is excess spending that goes to administrative waste, excessive profits, unfair prices, and treating illnesses that could have been treated earlier or prevented altogether with basic preventative care. Strong penalties and accountability mechanisms are needed to ensure the effectiveness of the growth target and slow down healthcare costs for California consumers. Thank you.
Thank you. Back to the podium.
Good afternoon, Ryan Miller on behalf of University of California Health, representing UC's 6 academic health centers and 6 schools of medicine. First off, want to appreciate the discussion on the matter of the non-federal share. As Director Landsberg noted, public hospitals in California, such as those operated by University of California counties, are the only hospitals that don't receive direct general fund support. Rather, we self-finance the non-federal share, so just appreciate the acknowledgement of that. We also appreciate OCA's proposed 2-step approach to penalties and support OCA's proposal to consider penalty adjustment factors and other relevant circumstances before determining a final penalty. However, we are concerned that OCA's proposed methodology for calculating an initially commensurate penalty may produce starting penalty amounts that are disproportionate to the statute's objectives. We encourage OCA to consider additional justification factors to ensure reasonable penalties. We noted several potential factors in written comment to the board. In addition, we encourage OCA to consider UC's role as California's public academic health system. In fiscal year 25, our academic health centers provided an estimated $4.7 billion in uncompensated care associated with Medicare and Medi-Cal. And in addition, our medical centers contributed more than $1 billion in support to UC's schools of medicine. We encourage OCA to consider these public benefits in the application of penalties. As I noted, we submitted a written comment on this item, as well as on the spending measurement methodology and the enforcement penalty policies generally, and appreciate OCA's and the board's consideration of our recommendations. Thank you.
Thank you. Back virtually, Tina, go ahead.
Thank you. Good afternoon. I serve as the Sacramento Market President for Dignity Health. Dignity Health and our 29 California hospitals strongly oppose the proposed penalty structure. As is, it needs more work and further validation. As the largest Medi-Cal provider, just last year we had more than 800,000 inpatient days and 1.2 million outpatient visits. This commitment comes at a cost. After all supplemental payments, including the provider fee, we lost nearly $500 million at cost. Reimbursements don't fully cover cost, and they vary greatly from year to year based on when the provider fee is approved. To be fined for Medi-Cal rate changes is just wrong. Additionally, Medicare fee-for-service rates are set by the federal government, and most Medicare Advantage rates are a percentage of fee-for-service. Why would OCA consider governmental rate changes as being punishable by fines that must be borne by hospitals? For context, in fiscal year 2023, Dignity's total revenue was $11.7 billion, excluding COVID-era FEMA payments. Our operating loss was $170 million. Our EBITDA was $400 million, resulting in net income of $50 million. Using OCA's structure, we calculated that the total all-payer penalty would be $631 million, which is nearly 6% of our revenue. And even if you take just the calculated commercial penalty of $117 million, these exorbitant and unreasonable penalties would debilitate our system and require reductions in workforce, service lines, if not entire hospital closures. Combining an untested hospital spending measurement methodology with OCA's recommended penalties produces outlandish results. Let me give you an example of how this penalty structure goes wrong. Based on our modeling using data from one of our hospitals, outpatient commercial payment rates increased by 34%. One reason is that their measured visit intensity weights decreased by 17%.
2 minutes.
Let me assure you, we did not negotiate a 34% increase in outpatient rates, yet we would be penalized as if we had. The findings being considered by the office would eliminate our ability to meet community and capital demands, including seismic compliance. We implore the board to step back and reconsider the impact of this penalty structure on access to care and the sustainability and fiscal solvency of healthcare in California. Thank you.
Thank you. Back to the podium.
Secretary Johnson, members of the board, OCA staff, I'm Steve McDougall with CFT, a union of educators and classified professionals. Just taking count, we're one egregiously high-cost hospital away from having a quorum of them here today. We'll see if that changes. One thing's for sure. As consumers, it's our money that we've earned for compensation in lieu of salary. But we do not get to be involved in the contracts between the insurance networks and the providers because those are confidential and proprietary. We don't have a chance. All we get to do is pay up once an actuary puts it into their calculator. That's all we get to do. Unless we choose not to access our healthcare benefits and skip things. As a seasoned classroom teacher, one thing I do know. Behavior correction will not change if the consequence has no meaning or not enough meaning. We can't deal with the time element of behavior change because it takes years to get things rolling. But it needs to be meaningful. Quite frankly, short of going to single payer, this is all we've got, and it's got to work. Thank you for listening. Appreciate it.
Thank you. Going virtually, Pooja, go ahead. Pooja, I'm sorry. I know this is the second time around. We're still not able to hear you on this end. So if you're seeing that mic button grayed out in the top right-hand corner, we don't have a technical way to address that, so you might have to dial in. And I'm sorry if we miss you for this comment period. There'll also be a general public comment period at the end of the meeting. So I'll go back to the podium.
Good afternoon, Chair and members of the board. My name is Chloe King, representing Memorial Care, a nonprofit healthcare system in Southern California with 4 hospitals and over 200 ambulatory sites of care. For over 10 years and predicated on the Affordable Care Act, Memorial Care has been revolutionizing value-based care to improve access to quality care for patients and at the same time driving down the total cost of care. This means driving affordability in healthcare. The system's leadership and board of directors have supported a model to increase healthcare quality and access while decreasing per capita costs, which has been at the forefront of the system's clinical and business strategies. During Memorial Care's February 2024 OCA board presentation on cost-reducing strategies, our CEO stated how it takes time and investment to shift business strategies and to build a network of community-based sites of care to support innovative value-based models of care. However, as pointed out by board member Dr. Pan, he asked if Memorial Care could squeeze any more savings, having done so much already in bending the cost curve, and if we could meet this 3% spending target. As we explicitly stated at the meeting, it would be unlikely we could meet the proposed 3% 3% spending target, since we have invested in many of the tools to reduce the cost of care for health plans, employers, and patients for over 10 years. As a result, we are concerned over the proposed fine structure, which would be disastrous for the patients we care for across our system. Please understand the chaotic environment health systems are currently operating under, with looming federal Medicaid cuts impacting the state and our hospitals, while all under the backdrop of the continued inflationary cost drivers on labor, drugs, and medical supplies that we have no control over. Memorial Care asks OCA to look for a collaborative approach to enforcement that provides hospitals with a meaningful opportunity to improve spending trends. We urge the board to consider changes to proposed enforcement regulations that balance affordability with continued access to care. Thank you.
Thank you. Looking virtually, Anna, go ahead.
Good afternoon, Chair Johnson and members of the board. My name is Anna Vasquez, and I'm speaking on behalf of North Bay Health. North Bay Health is concerned that the proposed penalty structure may have unintended consequences for patients and communities. Penalties should recognize the significant cost pressures facing providers, including labor, pharmaceutical, and medical supply costs that are largely outside of their control. North Bay believes penalties should be used only after providers have been given a meaningful opportunity to implement performance improvements and demonstrate progress toward meeting spending targets. Excessive penalties risk diverting resources away from patient care, workforce investment, and community benefit programs. For community-based health systems, these resources are critical to maintaining access to care and meeting local health needs. North Bay respectfully urges OCA to adopt a balanced penalty framework that supports affordability goals while preserving patient access, workforce stability, and the long-term sustainability of California's healthcare system. Thank you.
Thank you. Back to the podium.
Good afternoon, everybody. Cesar Lara with the California Federation of Labor Unions. We support strong penalties based on California law, not wimpy penalties for big insurers and hospital chains. My families that we represent 2.3 million union members, 1,300 different locals, 2.3 million consumers across California. And we pay a penalty when we skip going to the doctor or getting a prescription or needing healthcare should not be penalized by out-of-pocket cost. Strong penalties are needed. We strongly support penalties above 100% to encourage big hospitals and insurances to slow spending growth and meet the target needs. At the end of it, these penalties are not done in isolation without a PIP. And understanding that this board should look at higher penalties above 125% if behaviors are not being changed. The purpose of a PIP, the purpose of the penalties is to ensure that the consumers in that community have access to it. We have here some hospitals that are in Monterey County. I am a resident of Monterey County where they have more than $1 billion in reserves. And so we ask ourselves, whose $1.3 billion in reserves is it? Is it the hospitals or is it the profit they gouged from our community there in Monterey County? Your investigative study shined a lot of light on it. And so we ask the board to really look at these penalties as making sure that those that are looking in through a window, and the window is a barrier, it's cost, that we want a healthier California. We want community to have accessible healthcare. And so many residents, because of the cost of healthcare in many communities, do not have that. So we ask this board to go ahead with the penalties and work with them to change behaviors, to make sure that whatever you do is consumer-centered, where we need to ensure that consumers have affordability to healthcare, because at the end, we need a healthier California. It's cost efficient and it's better for California. Thank you.
Thank you. Looking back virtually, seeing no hands raised at this time, reminding anybody that might be dialing in, you have to press *5 to raise your hand. Looking back to the podium.
Good afternoon, Board. Katie Bassler, Monterey County resident. An earlier speaker started with the words real world conditions. And in Monterey County, your own report, as referenced by the previous speaker, demonstrated that the market has created an untenable situation for our community. One of your statements is, quote, escalating penalties must be large enough to deter future noncompliance. That is why I stand here. Whatever the percentage is that the board decides on, it has to be such that it changes the behavior. To be clear, Monterey County has been one of the most expensive healthcare environments nationally. So speakers can talk about this state or that state. In Monterey County, we have seen that our environment has been highest for decades. We simply cannot afford any more increases to our healthcare, and it is due to our local hospitals. There are very few of us here today, and there are a lot of representatives from hospitals, and that's because the workers are working. So I stand here as a voice for so many educators, for so many workers running and feeding our economy. Please know that in Monterey County, we already know it's too late. Thank you.
Thank you. Looking back virtually, seeing no hands raised, noting for the record, we have about 60 virtual attendees. We'll go back to the podium.
Thanks. Good afternoon, Ellie Mainshine for Sharp Healthcare. Sharp's, as you've heard, Sharp supports OCA's affordability goals, but we have significant concerns about the spending target penalties and the enforcement framework as proposed. First, I want to thank you for the discussion about and the recognition of the provision of the federal share piece for Medi-Cal, but I do want to clarify that this is not just a private hospital or a public hospital program. Private hospitals also contribute to the non-federal share, and that should also be considered as part of the conversation. But looking to penalties should not be imposed until OCA has established a fair, transparent process for evaluating why a hospital may exceed a target, including clear criteria, meaningful remediation, and official waiver or exemption process. The framework that we are considering today, or you are considering today, excuse me, is premature. OCA has not clearly defined how hospitals will be measured against the spending target or how adjustment factors will apply, including, and very importantly, the alternative payment methodologies, the APMs required in statute, which was not included in today's presentation or any previous documentation. Recognizing hospital APM utilization is essential to align enforcement with the statute and the state's affordability goals. Second, plan paid claims are not an accurate measure of hospital spending or performance. Health plans often deny, downcode, delay, or underpay claims. These claims-based changes are not changes to the care we have already provided or the cost incurred to provide that care. Basing enforcement on health plan payments risks treating payer practices as a hospital cost growth issue. Third, OCA has not established a formal transparent waiver process for justifiable spending above target. Director discretion is not a substitute for clear standards, timelines, documentation requirements, or a clear pathway for hospitals to explain legitimate cost growth, including legislative mandates, workforce obligations, public program underpayment, and investments needed to preserve access, quality, and safety. Financial penalties will not lower the cost of care. They will divert resources from patient care, workforce stability, emergency services, behavioral health, and access for vulnerable communities. I want to share with you my story. I moved to California from a healthcare desert in Idaho. The only cardiologist in my community failed to identify my father's heart defect, and his life was spared only because we sought care here in California. But OCA's proposed enforcement and penalties would result in a California that reverts to the care deserts of rural Idaho in the 1990s. Thank you.
Thank you. Seeing no one at the podium and no hands raised, that concludes the first public comment on this item, and we will have an additional public comment at the end of the item.
All right. We'll now discuss what we're calling procedural penalties compared with the spending target penalties. And these are outlined in the statute under Health and Safety Code section 127502.5 H1. Per statute, OCA may directly assess administrative penalties when a healthcare entity does any of the following: willfully failing to report complete and accurate data, repeatedly neglecting to file a performance improvement plan with the office, repeatedly failing to file an acceptable performance improvement plan with the office, repeatedly failing to implement the performance improvement plan, knowingly failing to provide information required by this section to the office, and knowingly falsifying information required by this section. Some considerations for these penalties include that the procedural penalties should enable OCA to address non-compliance with enforcement actions, including public testimony and performance improvement plans. Procedural penalties should encourage entities to participate in the enforcement process, and procedural penalties can potentially be issued in addition to spending target penalties, depending upon the circumstances of an entity's compliance or non-compliance with the enforcement process. Next slide. This slide shows part of what OCA is recommending for procedural penalties. The left column lists the penalties outlined in statute, and the two columns on the right share OCA's recommended approach for calculating those penalties. For sections B, C, and E, OCA is recommending per day penalties. For D and F, OCA is recommending a flat penalty. And for A, the board has already approved data submission penalties. In the following slides, we'll share more details about these recommendations, and we'll pause for a discussion after each. Next slide. So this slide shows more details about OCA's recommendation for repeatedly neglecting to file a PIP or an acceptable PIP, or knowingly failing to provide required information. OCA's recommendation for these violations is a penalty of up to $10,000 per day. Here, repeatedly is mentioned twice, and repeatedly means not filing a PIP or failing to file an acceptable PIP more than once. And a few notes about this recommendation are that depending on the entity's compliance with the enforcement process, spending target penalties may still be issued in addition to procedural penalties identified above. A per day penalty prompts entities to take action to prevent penalties from continuously accruing, and $10,000 per day aligns with other programs. The California CPUC commissions $5,000 to $20,000 per day financial penalty for failure to submit supply and pricing information, and California Department of Healthcare Services has an up to $25,000 per day for financial penalty for Medi-Cal managed care plans that fail to implement corrective action plans. These penalties increase beyond those initial amounts. So next slide, we'll pause here for discussion on this item, which will lead to a board decision as indicated by the green arrows. Does the board have any initial feedback on the per day penalty structure outlined above?
I'm going to do these section by section. So this is just feedback on provisions B, C, and E here about a per day, 10,000. Rick?
Could you go back one slide, please? The bullet, depending on the entity's compliance with the enforcement process, spending target penalties may still be issued. Can you say a little more about what you're imagining there?
Sure. I think what we're indicating is that depending upon the exact facts of a particular situation, it's one of the concerns was if an entity decides to simply just not submit a PIP, can they use that as a means of evading spending target compliance or spending target penalties? And our response to that is no, that's not.
I mean, I guess the $10,000 a day is quite small compared to the potential penalties for exceeding the spending targets. And I can imagine sort of without that bullet, that to Don's earlier point, for some entities, it might just seem like a good cost of doing business. But that middle bullet says, no, this is not a way to avoid compliance with the spending targets entirely.
That's correct.
Thank you.
With the data submission, we were told that we could, at the same time as penalties, seek go through administrative legal procedures. Is the same true here? And, is there a point at which we could actually go to spending target enforcement, even if an entity hasn't filed a PIP and is racking up these $10,000 a day fines?
I don't want to speak prematurely. I would rather come back to that question and that scenario and talk through what that could look like after we've consulted with our
Not seeing any other feedback. Why don't we keep going through?
So next we have OCA's recommended penalty amounts for repeatedly failing to implement a performance improvement plan and knowingly falsifying required information. OCA's recommendation is a one-time flat penalty of up to $500,000 for these violations. He repeatedly means failing to implement a PIP more than once, which could mean failing to implement more than one component of a single PIP or failing to implement multiple PIPs over an extended period. A few notes about this recommendation. Depending on the specific facts of an entity's compliance with the enforcement process, spending target penalties may still be issued in addition to the procedural penalties identified above. A flat penalty is appropriate for these violations because OCA is no longer attempting to compel an action. The entity has already failed to implement the PIP or has already falsified information. A flat penalty of up to $500,000 does align with other states' approach for entities that did not implement a PIP.
CJ, can you, on the PIP idea, the whole concept of a PIP is to try to get spending down. And so if an entity comes in with a PIP, they have a number of components. Some of the components turned out to not work, but they are moving in every other way to implement the PIP and to reduce spending. This would imply that a procedural penalty might still be in order because they didn't implement a particular component in the PIP?
It could, but it would depend on if, if it's a situation where, maybe they projected they would be at a certain point in time, but, that maybe they were off by, some amount of time, then, it would need to be a fact-specific analysis on kind of whether they were, blowing it off entirely, or it's kind of just more of a the timeline may not have been aligned perfectly with that milestone.
Yeah,
It's going to be very important for us to get the PIPs right? So entities are going to come forward with the PIPs, but I mean, as folks have noted, it really is and we've talked about a lot, it is a progressive enforcement approach. And the idea is that we try to, as you stated, try to help the entity reduce their spending and only do the enforcement penalties if they fail to comply with the PIP.
Yeah, I mean, so I don't have any issue at all on falsifying information like that. That's just full stop. We should go ahead and do but I think performance improvement plans are that. They're plans, quality improvement plans are quality improvement plans, quality improvement efforts. 80% of them might work and 20% of them don't. And so I just think we should be mindful of the direction of compliance with a PIP. Even if there's a particular component that isn't working, I don't think we'd be in a situation where we say they're not complying with the PIP overall. So that just seems, it's a plan.
Yeah.
And there will be no perfect plan. There just won't be. And so I just think the flexibility around a performance improvement plan, the directionality of whether that's occurring, you might come back and say that piece isn't working, we're going to try this piece. I think we should not be in a penalty mode when we're in a performance plan trying to get them to comply with a spending target.
And can maybe I ask and build on that just to say, I read this more as a failing to implement the plan as opposed to implementing the plan and not getting the outcome. I just want to make sure, though, that that's correct.
Yeah, I think that's how.
This is that we had a plan and then we didn't follow the plan, not that we followed the plan and the outcome wasn't what we. Correct. Okay.
If there were, we've talked about PIPs, if there's multiple goals and writ large, they very few or none, or as many of the substantive ones, just simply there was not an attempt to implement them. I think that's more what we're talking about, where the actions that were agreed upon were not attempted.
Yeah, and I'd clarify that this is at the discretion of the director, so it's not automatic that you miss a milestone and you're getting fined. So it is meant to be really for those situations where we see a repeated action.
To me, there's a non-cooperation component of both of these flat and the per day.
I think that is the theme. The question is, can we frame these in that light?
Yeah, this is similar to my previous question, the willful non-implementation, if it's not done in coordinate, if they're not implementing a portion of their PIP, but it's done in coordination with the office, that gives the director, some discretion. That's good. That the knowingly falsifying information, I would be concerned that a flat $500,000 cost of doing business situation might be problematic, and I just want to make sure we're not tying the hands of an administrative law judge to throw the book at somebody who's knowingly falsifying information and deceiving the office.
So we can go to the next slide, but I think we've already started the discussion. No, that's all right.
Yeah, I just sort of following Sandra's point, and I don't know if or how the language, should be changed or could be changed, but if a performance improvement plan, I can imagine, would have sort of phase 1 and phase 2 and phase 3, and if after phase 1 or phase 2, it seems like change of direction is needed, and so phase 3 shouldn't be implemented, I'm sure none of us would want to say that that's an entity refusing to implement the performance improvement plan, and to provide some reassurance to covered entities that might be worried about that. If it's possible to provide that reassurance, I think it would be helpful.
Yeah, the entities would be providing periodic progress reports and meeting with the office on a regular cadence. So, if something's not going on track, that there would be that dialogue with the entity, and modifications could be made to the PIP.
We did talk at the last meeting about this administrative alternative to fees. And so I don't see anything in this fee structure that would preclude, if somebody's falsifying information, that appropriate other entities of the state would not also be able to intervene in whatever jurisdiction they have or whatever their statutes allow them to have. There's nothing about this fee that would preclude that. Is that correct?
Correct.
We can, if we're done with discussion, we can go to the next slide. I'll summarize the next steps. So we'll have a board vote on, we'll schedule a board vote on spending target, penalty scope, range, and justification factors. We'll have a board vote on procedural penalties. We'll schedule this for August, and we'll discuss draft regulations for spending target enforcement. And now I'll turn it back to the chair to facilitate discussion and/or public comment.
Great. Thank you very much. Any other questions or comments from the board? Okay. So if you have public comments related to the procedural penalties, public comment related to the procedural penalties, we welcome that now. Thank you. We'll now take public comment on this item. Please limit your comments to 2 minutes. If you're attending virtually, please raise your hand. Otherwise, step to the podium, look into the podium. Go ahead.
Beth Capel, Health Access California. The board's already had most of the discussion that we would offer. We will note again that this is for an entity that knowingly, willfully, or repeatedly fails to do something or does something. We call these obstruction penalties, to obstruct the process by which OCA is doing its work. We would note that under A, the willfully failing to report complete and accurate data. You've had one example, which is the submission of THCE data, where you already had the example of plans agreeing to, submitting. There may be other instances in which you require data and entities willfully fail to submit timely and complete data. So we would encourage we don't view that as a closed topic, just one we're not considering today, that there will be there may be over the life of this program, other instances where there are willful failure to submit. We appreciate the per day penalties. We know how those rack up and how those have a major deterrent effect at the Department of Managed Healthcare. We have some questions about the flat penalty and whether it has a sufficient deterrent effect for the same reason that some of the board members do. And we appreciate the clarification on the interaction with the spending target penalty. Thank you.
Thank you. Looking virtually, seeing no hands raised, going back to the podium.
Hi, Ben Johnson from the California Hospital Association. Like to stand by a lot of the comments that were made by the board, as well as actually the prior commenter. State law is crystal clear. Yeah, it's not every day. Maybe. State law is crystal clear. In its findings and declarations, the legislature states that the spending targets must be enforced in a progressive manner such that entities are assisted to come into compliance with the cost targets through technical assistance, performance improvement plans, before assessing administrative penalties unless there are egregious violations as specified. Therefore, it gives guaranteed opportunities for remediation, lays out step-by-step process for entities to improve, and it allows for penalties in two circumstances that we discussed: failure to meet the PIP and the associated spending target, or the procedural penalties such as willful non-submission of data or not filing a PIP, or in statutory terms, the egregious violations of the law. We would also note that the procedural penalties we don't think are minor. $10,000 a day penalties add up to well over $3 million over the course of a year. This could be well over 10% of the total revenues of a small hospital. So they would be very, very significant. We continue to review this recommendation and look forward ultimately to providing further comments. Thank you.
Thank you. Looking virtually, seeing no hands raised, we'll go back to the podium.
Katie Bassler again. I will be much shorter. The office can't really address affordability problems if entities aren't submitting the complete and accurate information. So the procedural penalties, they'll help ensure that the office gets the information it needs in order to enforce the targets. Thank you.
Thank you. Looking virtually, seeing no hands raised and no one at the podium, that concludes the second public comment period on that item.
Thank you very much. And thank you for the continued work of the team as supporting the board and walking through the structure, and again, for the public's comments. We are going to move to our final informational item of this afternoon. That is the Cost and Market Impact Review Regulations, Introduction to Regulatory Texts. We welcome Assistant Chief Counsel Heather Hoganson for this item.
Sorry. Good afternoon, members of the board. Once again, I am standing, sitting here in front of you, between you and getting to warmer climates outside. So as I mentioned last month, AB 1415 required us to make some amendments to our transaction review program regulations. And if we can go to the next slide. We did discuss those, and we published a draft packet of regulations on May 22nd. We accepted comments until June 11th. That was about 21 days, informal comments. We received 11 comment letters online, and then we also received one in the mail that came yesterday that had been postmarked appropriately, but had not reached us before posting. But we are considering all of them as we go through. And in the next 4 slides, I just have some general themes that have emerged that we've been working on. In terms of filing, we've had multiple requests to prevent duplicative reporting, and it's also in AB 1415 as enacted. We had included some language in our regulations to do cross-referencing. We had requests for additional clarification on that. We are planning on codifying our existing practice. A lot of times a law firm will call us on behalf of one or more parent sibling organizations to figure out how best to file. And we had those conversations with law firms on a regular basis, how they can prevent duplicating information. And we'll continue that. We'll put that in the regs so it's clear to everyone that they can do that. One of the requests was to allow for joint submissions. We specifically had looked at that originally and declined to do that because we want to be able to, for transparency purposes, have the submitters answer the questions so that people can see, what business lines they're doing. And then also to incorporate by reference information previously reported to other regulators. And quite frankly, we don't always have access to other departments' information. So there are some things we can do, some things we can't. In terms of defining healthcare entities, we've had requests to not include owners. In terms of just defining the transaction itself, we had some requests to expand the definition. We had other requests to narrow the definition. And we are looking at all of them seriously. I don't mean to over summarize, but we are getting both ends of the spectrum for most of these themes. In terms of real estate investment trusts, we did have a number of comments that requested that we not consider them, that we delete them, that if we are considering them, we do it on an expedited review or have thresholds to otherwise narrow or exempt their review. We also had comments on the other side saying, we really should be asking for the actual agreements to be submitted. We need to be tracking these significant issues. The sale of transfer of ownership of a healthcare real estate can have substantial implications for provider stability, patient access, affordability, and long-term service availability. And sale leasebacks arrangements, for example, frequently involve transferring ownership of facilities to a third party while requiring the provider to continue operating the facility under a long-term lease, which can create substantial ongoing financial obligations. So we definitely want to look at them as other states have experienced the Steward Healthcare collapse. We want to make sure that we are seeing those and looking at them. And then with regard to serial transactions, we had some comments that requested that we shorten our length of look back from 10 to 3 years. And we had other comments to say that we should maybe consider aggregating more robustly the physician practices under 25. And so both sides of the spectrum, we do feel that 3 years is too short of a look back. We went with 10 for a reason. Sometimes things just don't emerge until you've had a few extra years. On the next slide, we had management service organizations. Again, comments about whether the regulation was too narrow or too broad, expanding who should file in terms of thresholds or narrow that. We also had requests to include a normal course of business exclusion and not to narrow the definition of the statute. OCA has identified filing thresholds based on the size of the MSO and their influence on the healthcare market as a way of determining whether or not we should be reviewing them. and hospital-owned MSOs with one or more physician organization, client, or affiliates are large enough and have enough influence that they may materially affect each of the factors for control. So we are definitely looking for control in this area and whether or not the MSO could have a significant impact on the healthcare market functioning, patient care, and prices. We are considering some changes regarding the language for employment or otherwise contracting with physician owners, physician organizations. So we are still working through those comments, but they were voluminous. So. And then the thresholds for MSOs. An MSO that shares directors or governing body members with a healthcare entity may be able to influence decision-making of the healthcare entity. And so we really want to make sure that we're checking that and following that on transactions. We're also looking at the 2025 final rule for the pre-merger notifications from the Federal Trade Commission and capturing all the different components that go into those agreements. Our next slide themes include private equity and private equity portfolio disclosures. Again, we've had comments about narrowing who should file versus expanding who should file, what sort of interest private equity should have before it rises to the level of us looking at it, whether or not we should also consider exit transactions or divestitures. And the legislative analysis for AB 1415 did cite evidence associating private equity ownership with higher costs, lower patient satisfaction, worse financial outcomes, and quality concerns in certain settings. So the legislature has determined that transactions involving these entities warrant additional transparency and review. So we don't want to give short shrift to that. We did in our comments have some low thresholds. We've had requests to raise those thresholds to 25 or 40%. A 10% threshold would align with the Hart-Scott-Rodino filing requirements, and Massachusetts does use a voting 10%. So we are considering that, but limiting review to majority interests of 25% would fail to capture many arrangements capable of affecting provider behavior, strategic planning, staffing decisions, capital investments, and service availability. So we want to make sure we have a good mix there. We're focusing on practical control issues in some of the language of the regulations. And so we have had significant comments, as you've seen, pages and pages of them, but we want to make sure that we are tracking all of the transactions that are going to affect the healthcare market. Again, with the portfolio disclosures, narrowing requests as well as expanding to capture additional portfolio organizational themes to see where these private equities are investing their money and is it something that's going to overlap and impact. And then on the last slide, two other thoughts, confidentiality themes. We had requests to not require submission of anything confidential or public or submitted to another agency. We had requests to allow more redacted information to be submitted. We've had many requests to deem more documents automatically confidential, as well as comments saying, do not presume confidentiality for anything. And then we did have a request for us to require the Attorney General to keep any referred matters confidential. On confidentiality, we did propose our definition of non-public to be based on not only OCA's statutory language, but also the California Financial Information Privacy Act. And we have found that submitters may always request confidentiality and justify it. And there is significant back and forth on almost every single filing, if not every single filing, about whether or not certain documents should be confidential. And we're asking for them to justify. And we have expanded the how-to guide in our regulations of how to do that, what we're looking for, and what warrants it not being transparent to the public. So we do want to be cognizant of that. And then what we can require the Attorney General to do is often diplomatic. So they do have their own requirements and their own laws. And then finally, for org charts, we had some requests to increase the reporting threshold to owners possessing governance rights versus decreasing those thresholds, whether or not we should delete the subsidiary organizations or include them. And we've been going with a 5% ownership for aligning with, for instance, the California Department of Public Health, and also some federal requirements. This provides a representation of ownership so that we can know in context the transaction and how that will play out. And then so the next slide. Those are sort of the themes we've had. All the emailed comments were provided in and posted on the website, all 70 some pages of it. But with all that, wanted to get the board's input on the draft text itself or any of the comments received, and I will turn it back over to the chair for comment.
Thank you. And thank you for summarizing that 70 some odd pages of public comment in this fashion. Any additional comments or questions from the board?
What's the next steps now on the regulation?
So the next steps would be to put all of this in, and then it would be an emergency regulation process to go to the Office of Administrative Law. There would be a 5-day public comment period that we would send out advance notice on our website for, and then folks could comment. The Office of Administrative Law reviews it, and we either respond to those comments directly, or if our finding of emergency or rationale document already explains it, then the Office of Administrative Law might not require further comment.
Just to be clear, this is the last time the board will see this in this format.
Yes.
My general sense is that your gist is to require disclosure about anything that could plausibly affect the market, and I really appreciate that. Just one technical thought I had. I'm no expert on REITs in the healthcare industry, but in other parts of the real estate market, it is common for REITs. The sale leaseback certainly imposes long-term financial implications, but it is not uncommon for REITs to exercise very direct control over budgets, the veto power over budgets, authority over hiring of executives and maybe other employees of the manager of the operating entity. And that language might not necessarily be in the sale leaseback agreement. So I just flag that for you in case that's happening in the healthcare sector as well.
Okay, not seeing any other comments or questions from the board. This is public comment on the public comment summary. I think with general public comment. So with that, I will turn it over to you, Jane.
All right, we'll now take public comment on this agenda item, and as this is the last item, we can also take general public comment. I will look to the podium, seeing no virtual hands raised.
Beth Capel, Health Access California. We were the organizational sponsors of AB 1415, and we offered detailed written comments based on our work on it and on other legislation dealing with private equity and hedge funds. I think the research on private equity, which was cited by Ms. Hoganson from the analysis, is pretty clear. The result is higher prices, dangerous health outcomes, reduced access, worse financial outcomes for the entity that's invested in, And so we support the transparency in the regulations. We did offer comments that the definition of management service organizations is narrower than the definition in the statute, and we were troubled by that in terms of market impact. For example, a single MSO could be negotiating contract terms for a single physician organization that could drive prices for a market segment like ER doctors or other hospital-based physicians. And so we did offer alternatives on the definition of MSOs. We very strongly support the expanded provisions on confidentiality, including the plain statement that information which is otherwise publicly available shall not be deemed confidential. You would not think we would need to say that, but sadly, apparently that's needed. Thank you.
Thank you. Looking virtually, no hands raised, noting we have about 60 virtual attendees. Back to the podium.
Hi, Ben Johnson from the California Hospital Association, here to express concerns on the proposed CMIR regulations insofar as they conflict with the letter and intent of AB 1415, would upend standard and beneficial business practices, and would hinder collaborations that are needed to sustain access to care in an increasingly unstable environment. We stand by with our other provider colleagues in asking for important changes to the rules to address various challenges. And our comment letter goes into significant detail, including on the rationale for each requested change. Among our major concerns are the fact that the draft regulations define entities that own, operate, or control a provider, regardless of whether or not the provider is currently operating as healthcare entities, even though AB 1415 and therefore current law clearly defines such entities as noticing entities subject to different requirements overall. Additionally, despite state law only allowing OCA to review material transactions, the rules set no materiality thresholds for transactions involving management services organizations or real estate arrangements, even those that have no material impact on the control of governance of healthcare entities. The rule further falls short of upholding the legislature's direction to exclude hospitals and health systems from its definition of MSOs. And finally, under current rules, OCA prudently exempted transactions among healthcare entities in the usual course of business or where they're doing internal restructuring from its noticing requirement. This prevents extensive noticing and prolonged delays for transactions like leasing new office space, updating EMR systems, or securing new loans. However, the draft regulations do not extend this critical exemption to the new noticing entities. So to enable noticing entities to maintain even basic operations, OCA must extend this critical exemption. Given the scope and complexity of the proposed regulations and the extent of the needed revisions, we request OCA to release a new draft of the regulations for comment prior to starting the formal process at the Office of Administrative Law. This would help stave off problems before implementation that would require subsequent cleanup. Just very briefly for general public comment, separately, we appreciate the opportunity to comment on the draft regulations on the non-supervisory organized labor cost adjustments. These rules reflect important policy development and will be operationally complex for hospitals. We therefore ask OCA to reconsider its 20-day timeline to review these rules to allow more thoughtful comment. Thank you.
Thank you. Looking virtually, no hands raised. Back to the podium.
Hi again, Stacy Bratcher, Cottage Health from Santa Barbara. I want to echo my colleagues' comments from the California Hospital Association, but just to give you a little more color on why we're concerned with these CMIR proposed regulations. You may not realize that hospitals with medical foundations or MSO structures have a lot of transactions for their friendly medical groups. And these are what we would consider routine transactions, which the regulations don't make exception for. And I would just, I like to say, when you all sneeze up here in Sacramento, it raises costs down in Santa Barbara. And so for us, any kind of transaction that might impact our medical foundation or a clinically integrated network or other management services organization, I'm going to have to hire lawyers and consultants to prepare a submission to OCA. It's going to delay my transaction. And that, as I said, raises costs on our organization. And I don't know if you're aware of that the rules that you make here do have a real world impact on us. So I'd like you to just think about it a little bit closely and listen to what the California Hospital Association said. Thanks.
Thank you. No virtual hands raised. Back to the podium.
Thank you, Ryan Miller, UC Health. We appreciate OCA's engagement on the issue of the 1415 regulations and the opportunity to provide written comment. While we appreciate OCA's efforts to implement 1415 in a manner that promotes transparency and the efficient review of healthcare transactions, we're respectfully requesting several clarifications and revisions to the regulations. Specifically, request OCA clarify the scope of the MSO definition to avoid unintentionally encompassing integrated health system structures, modify the regulations to better protect documentation that is produced under attorney-client privilege, address the potential for transactions to be held up indefinitely due to delays by third parties by eliminating tolling based on requests to third parties, strengthen the confidentiality provisions to better protect commercial information and expressly eliminate duplicative reporting requirements. I heard staff mention something about that. I was in the back of the room. I'll have to rewatch the tape to play that back, but thank you for acknowledging that. Refer to you to our detailed written comments on that. In terms of general public comment, just wanted to also touch on the non-supervisory cost draft regulations and the detail about supporting documentation like CHA. We would request reconsideration of the timeline for that. It's a new process. We need time to be able to assess, whether the information being requested by OCA matches what we have, and just would request having more time for meaningful and thoughtful input on that. So thank you.
Thank you. Back to the podium.
Good afternoon, Chair and members of the board. Shireen Gadusi on behalf of the California Medical Association. We appreciate OCA staff's work and efforts on this important issue, and we appreciate the opportunity to provide feedback. We have a few concerns that we laid out in our comment letter in greater detail, but I'll just briefly recap the, I think, most important ones. The first thing is the conflation of noticing entity into a healthcare entity definition. We think that conflating these two distinct concepts in statute that are distinct in statute, but conflating them in regulation creates problems. This concept of healthcare entity is used in context outside of the CMIR requirements, spending targets being one example. And so trying to commingle them in some way will create some confusion and inconsistency. And it could also be read as applying these legal requirements to noticing entities. We also had some additional comments that would reduce, that are aimed at reducing the volume of extraneous material change transaction notices, as well as the workload that the staff would be sort of sorting through to ensure that you're able to focus on the transactions that truly warrant regulatory review. We do think it's really important to add MSOs to the usual and regular course of business exclusion, as the office has done with healthcare entities. For MSOs, they provide a suite of services that actually make it possible for independent and small physician practices to exist. And raising the barrier to entry for smaller MSO type services or businesses is actually going to potentially drive that market consolidation more quickly, because now only the larger businesses are able to meet the regulatory requirements of CMIR notices. And so you're not going to have quite the same number of choices if you're a physician organization trying to seek the services that are necessary for you to exist. We also think it's important for you to have entity thresholds for MSOs, as well as to truly focus on transactions that involve a change of control, ownership, responsibility, governance, et cetera. We look forward to continuing to work with OCA on refining these regulations. Thank you.
Thank you. No virtual hands. Back to the podium.
One last time, just general public comment. Tomorrow I get to attend RJPA's board meeting to discuss 26-27 budget, stop loss policy, and review our RX contracts, among other agenda items. For the 24-25 school year, with a very small COLA from the state, our members received no raise. However, our healthcare premiums went up 15%. For the 25-26 school year, any raise is still in negotiations, but the reduction to take-home pay is felt every day, and it's not looking any better for the 2027 rates. We appreciate all the data presented today, and we are living this data. Commercial healthcare costs in Monterey County are a constant concern for educators and other members of the community. Slowing the cost is urgent. I share this to emphasize that we need OCA to ensure that hospitals are held accountable. If they don't submit data, and especially if they miss the spending target. We all know that the working class has been and continues to struggle with inflation and constant increases to healthcare. We thank the staff and the board for all the work and thoughtful consideration of those who are most impacted. Tomorrow in Monterey at 1:30, there will be a number of decisions that are very uncomfortable for the trustees of the JPA. And ultimately, we know the answer begins with the hospitals adjusting their practices. Thank you and have a nice summer.
Thank you. Looking back virtually, no hands. Back to the podium.
Good afternoon. This says a lot about the California Labor Federation. And under general comment, tomorrow I'll be in Martinez, California, where I'll be facing 100 locked out refinery workers that are not being allowed to go to work. This is today their 59th day without being able to work. And I'll be working with Covered California to try and enroll as many of them into that program because we have members that have family members that have cancer and other big healthcare needs. And so as we go down this path, and I said it earlier, we need to make sure that we keep consumers at heart. And it's kind of heartening to hear industry come out to say no more transparency. We don't want more information. Consumers want it. At the end of it, so often, just like my colleague said, with the health trust, we just get the bill and we're told to pay it with not much transparency. And so many union members and so many workers don't have a union, have to figure out healthcare on their own. And when you have employers like in education or, some that I work with in agriculture that are facing 15, 20% increases in their health premium, while employers are not being able to put more on the table, it means that workers get a pay cut. They get less services. And so often we as unions have to go back and cut the level of healthcare that is provided because of plan to try and reduce costs to still keep it affordable and reachable for our members, especially if they have a percentage cost share. So as you do the work, in my 19 seconds left, before I'm the last speaker, just, remember consumers. Thank you.
Thank you. No virtual hands raised. Back to the podium.
Hi. Sorry. Hi, I'm Katrina Walters-White, and I'm giving comment for Pooja Lal with Next Gen Policy. She tried to call in but wasn't able to, so I'm reading off her comment for her. Pooja was calling in today because more than half of Californians, nearly three-fourths of Californians with low incomes, say that they skip or postpone care due to the cost. Californians are paying more for coverage in the form of higher premiums and deductibles and getting less and less for it every year after year. The annual report showed today demonstrates why OCA needs strong enforcement provisions to encourage big hospitals and insurers to grow with Californian wages. Otherwise, they will continue to blow past the spending target and our ability to afford our care. Californians pay a penalty every time we skip going to the doctor or delay getting a prescription on time. It's time we had enforceable penalties on the entities that are actually driving up costs for all of us, namely big insurers and hospital chains. Thank you.
Thank you very much, everyone. Secretary Johnson had to step out for a minute. I'm going to go ahead and adjourn us. We will not be having a board meeting in July. We'll be having an advisory committee meeting in July. You get the month off of July from board meetings, and we will be back here on August 26th. Thank you very much for joining us today. We are adjourned.